joining us at our new home here at the Atlantic Council. We're excited to be here, and we look forward to working with the team here to continue our work domestically and extend our reach internationally. I've heard a lot of chatter about the title of today's meeting, especially the part about the Twisted Sisters. Since I have a twin sister, I want to be careful here. The commission is cool, but I'm not sure we're that cool. We've titled today's meeting Twisted Sisters, Biodefense Supply Chains and Stockpiles, because these two elements of biodefense are tightly intertwined, sometimes reinforcing each other and sometimes codependent, and not necessarily in a good way. When supply chains break, stockpiles struggle to survive. When stockpiles fail to determine what they need, and when they need it, supply chains send the wrong signals to the market, and cascading consequences ensue. And we need to align the two so that this country can withstand the shock, the disruption, and the deliberate attempts by adversaries to manipulate or to cut off critical medical supplies. But let us start by receiving a welcome from the Executive Vice President of the Atlantic Council, Jenna Ben-Yehudi. Jenna?
Thank you, Secretary Shalala, and good morning, everyone. My name is Jenna Ben-Yehuda. I'm the Executive Vice President here at the Council, and on behalf of Fred Kemp, President and CEO of the Atlantic Council, and our Board of Directors, I'm really thrilled to welcome all of you here today for a milestone event, which is the very first meeting of the Bipartisan Commission on Biodefense and its new home within the Atlantic Council's Scowcroft Center for Strategy and Security. So, welcome. We often talk about inflection points in history, and today we are living through one. The convergence of biological threats, geopolitical instability, and rapid technological acceleration has only made it more glaringly apparent that biodefense is indeed a critical national security priority. And that's why today is so significant. We're bringing together the premier global think tank for strategy with a premier voice for biodefense policy. At the Atlantic Council, our mission is to shape the global future together with partners and allies. We strive for what we call programming with purpose. We don't do one-off events, we build movements, we drive policy, and we solve problems. For years, the Scowcroft Center has carried the torch of General Brent Scowcroft's legacy by advancing U.S. security through nonpartisan strategic foresight. By formally integrating the Bipartisan Commission on Biodefense into the Scowcroft Center, we're sending a clear message to Washington and the world. Biological security is national security. And by housing the Commission here, we're ensuring that the fight against biological threats, whether natural, accidental, or human-generated, is woven into the very fabric of American grand strategy. Usually, at this point in the program, I would introduce a specific keynote speaker, but today I want to introduce the true guest of honor, which is the Commission itself. Since its inception in 2014, the Commission has done more than just write reports. You've fundamentally altered the landscape of American defense. Before this commission existed, biodefense was often an afterthought, a line item buried in disparate budgets. But through their landmark report, A National Blueprint for Biodefense, and their relentless advocacy, the commission has achieved things that many thought impossible in a polarized Washington. They drove the creation of a national biodefense strategy. They championed the Apollo program for biodefense, setting the ambitious goal of taking pandemic threats off the table within a decade. They have successfully ushered dozens of legislative recommendations into law. And they've proven that biodefense has a strong bipartisan consensus, that the virus doesn't care who you vote for, and neither does this commission. So to the commissioners, the ex officio members, and the terrific staff who've made the transition to the Atlantic Council possible, welcome home. We are honored to be the platform for the next chapter of your impact. This brings us to the specific focus of today's meeting, Twisted Sisters, Biodefense Supply Chains and Stockpiles, and it's a fitting title. Supply chains and stockpiles are indeed like siblings. They are inextricably linked, occasionally dysfunctional, and neither can succeed without the other. And as we saw during the pandemic, a stockpile is pretty useless if you cannot replenish it, and a supply chain is fragile if you have no buffer. We're entering an era of great power competition where the logistics networks are no longer just commercial arteries. They're potential battlegrounds. And today we'll examine vulnerabilities in the global supply chain for medical countermeasures. We'll look at how we depend on foreign adversaries for essential goods. And we'll discuss the industrial strategies needed to bring the manufacturing capacity home. We have a long day of critical discussions ahead, so I want to thank the Commission team for organizing this and thank all of you for being a part of this inaugural meeting at the Council. It's now my honor to turn the floor back over to Secretary Shalala and the Commissioners. Thank you.
Thank you very much, Jenna. Thanks for that warm welcome. And let us begin with panel 1, and we've invited our new colleague, Matthew Kronig, a very distinguished political scientist and national security expert, to begin on panel 1.
Co-Chair Shalala, Co-Chair Ridge, honorable commissioners, esteemed colleagues, thank you very much for the invitation to be here today and to share my thoughts on this important topic. As was mentioned, my name is Matthew Kronig. I'm Vice President and Senior Director of the Atlantic Council's Scowcroft Center for Strategy and Security. And let me first just join Jenna in welcoming the Bipartisan Commission on Biodefense to the Atlantic Council. We're really delighted to have you. You're preeminent in your field, and we're honored to have you as part of our team. The partnership places the Commission's critical work on biological threats inside the Scowcroft Center, which is focused on developing sustainable, nonpartisan strategies to address the most important security challenges facing the United States and its allies. And we also honor the legacy of service of General Brent Scowcroft. In the Scowcroft Center, we do work on strategy, alliances, and defense, including resilience against shocks and disruptions. And we have done work in the past on biological challenges, but never in a sustained way. And so, again, so happy that we have the Commission now to be part of our work. So context matters, I think, for today's event. As this group knows, the House of Representatives this week will take up the annual National Defense Authorization Act, a powerful legislative vehicle that addresses the biological threat and the need for our military and federal government to prepare for future biological events. And I was very pleased to see this year's bill incorporate recommendations from the Commission from its most recent report, Battle Rattle, which focuses on military biodefense. The bill also addresses international competition in biotechnology and the national security imperative for the United States to take up its own efforts to win that race. And so another piece of context, of course, is last week the Trump administration released its new national security strategy. And while it didn't say much about the bio threat, it said a lot about supply chains and securing supply chains. And I think this is a challenge for biodefense, but also for the global economy. After the end of the Cold War, the United States attempted to cultivate China and others as responsible stakeholders in a rules-based international system. As part of that, we became increasingly economically intertwined. In recent years, however, with the return of great power competition, we've seen the downsides of being too economically intertwined with our adversaries like Russia and China. And so we saw with Russia's invasion of Ukraine the need to essentially decouple from the Russian economy almost overnight. And so now I think we're more carefully thinking about de-risking and securing supply chains with other adversaries like China. So this is in a lot of areas, critical minerals, but also in biodefense. Raising key questions like who controls the pharmaceutical and medical supply chains we depend on in crisis. How resilient is our industrial and health base if adversaries decide to exploit these dependencies? And will we approach allies as true partners in managing biological risk or treat them as competitors to be pressured? I've done a lot of research on strategic competition with Russia and China. And as we saw during COVID-19, health crises can destabilize the international system, weaponize interdependence, and accelerate strategic rivalry. So biological threats are not just health problems, but parts of great power rivalry and U.S. national security strategy. As I mentioned, the Scowcroft Center has done work in this area in the past. During COVID, we authored a global strategy for shaping the post-COVID-19 world. And we argued that the United States could use the crisis to kind of build back better and preserve an open rules-based system, and that we really should think about the interlinkages between health, the economy, governance, and defense that needs to be coordinated and integrated. So today's discussion on supply chains and stockpiles is a practical application of that argument. If we cannot secure the basic medical goods our society needs, our broader geopolitical strategy will fail. So the landscape we face today makes clear that biodefense will be a recurring feature of national security, not a one-off crisis. Supply chains are recognized as strategic terrain where states seek leverage over critical goods, from antibiotics to PPE and diagnostics. Economic and trade power are used as tools of coercion and deterrence, including over pharmaceuticals, where U.S. dependence on Chinese-linked inputs poses growing risk. Alliances and partnerships across the Atlantic into the Indo-Pacific are being tested by information operations, coercive diplomacy, and competing visions of international order, all of which complicate cooperation on biological threats. Within that context, we're seeing a rise in asymmetric warfare where biological threats are becoming tools of leverage. They offer a form of asymmetric warfare, cheap, deniable, capable of targeting civilians, infrastructure, and military readiness all at once. Just weeks ago, we saw Indian authorities foil a ricin-related terror plot with alleged links to Pakistani-based handlers. In a region that many already regard as a nuclear flashpoint, this is a warning that biological and toxin threats can become part of the escalation ladder. In Europe, we've seen Russia use toxins to assassinate dissidents. It's repeatedly used false allegations of U.S. and Ukrainian biological weapons programs to justify aggression. Iran, North Korea, Russia, and China continue to engage in dual-use activities that raise concerns about their compliance with the Biological Weapons Convention. In the event of a major power war with Russia or China, something I think that unfortunately is once again thinkable, there is, of course, the use of biological weapons attack. So that is why today's event is so important. More must be done to secure supply chains and stockpiles necessary for our survival, from PPE to diagnostics to therapeutics, how we can do so in a way that reduces our exposure to geopolitical coercion and strengthen American resilience. So again, I appreciate the Commission's focus on supply chains, and again, I'm delighted to welcome the Commission to the Scowcroft Center and to the Atlantic Council. Thank you again for the opportunity to join your inaugural meeting here at the Atlantic Council, and I very much look forward to the rest of today's discussion.
Thank you very much. If we can hold off asking you a couple of questions, let me introduce my co-chair, the very distinguished governor of Pennsylvania and former Secretary of Homeland Security, Tom Ridge.
Well, thank you, Donna. It's a great pleasure for me to join you today from the frozen tundra of northwestern Pennsylvania. Might as well be former governor of Alaska right now, and it's very significant today as we have this first meeting at the Scowcroft Center. I've been a long admirer of the Scowcroft Center and the work that it does. And I'm very grateful that we're able to find a way to collaborate our efforts, and very grateful to Fred Kemp and his team for making this possible. And for your leadership, Donna, thank you.
Thank you.
I made some notes here. I do have one question I'd like to inquire about, sure, if you don't mind. Doctor,
Go ahead, Tom.
this is a rather unique group of public servants that have been participating in this Bipartisan Commission on Biodefense. from your perspective, do our allies in Europe view the threat of biological warfare as seriously? Have they taken it up in a serious fashion? As you examine their strategy and their collaboration in the European theater, do you see any effort on their part to prepare for a biological intervention of some kind in the future?
Well, thank you very much for that question, Governor Ridge, and for your leadership of the Commission. As you likely know, the Atlantic Council was founded in 1961 to support transatlantic relations, and we've grown a lot since then. We're global, but working closely to strengthen the transatlantic community is still core to our mission. And so we're interacting with U.S. and NATO and allied officials almost every day. I think they do see the threat from biological weapons, and they are taking steps to prepare. One body of work we've done in the past, we had some work sponsored by the State Department where we ran workshops on CBRN threats in Europe. And so on the ground there, working with officials, journalists, and others. And as I mentioned in the opening remarks, we've seen that Russia has used biological weapons, toxins, to assassinate dissidents throughout Europe, which is a threat. We've also seen Russian disinformation around WMD and biological weapons threats. And so part of the work that we wanted to do was to help educate journalists and others who would be reporting on these incidents so that they wouldn't fall for Russian disinformation and provide a more accurate picture to their populations. But I think the short answer is yes, our allies are right up next to the threat of Russian biological threats, and I think they'd appreciate any insights we can share about how they can better prepare for any eventuality.
Before I go to the other commissioners to see if they have any questions, let me make sure that I introduce our newest commissioner, Congresswoman Anna Eshoo, who has represented California's Silicon Valley, including Stanford University, for 32 years. She's known for her expertise on technology and health and energy and her bipartisan efforts. She co-chaired the Biodefense Caucus with Susan Brooks, so that we have both members now as commissioners, and she was the ranking member of the Subcommittee on Health in Energy and Commerce, a very distinguished member, former member of Congress, and we're delighted to have her joining us.
Thank you.
And let's see who might have a question for Matthew.
I might have a question.
Go ahead, Tom.
First of all, thank you, Matthew, for your excellent introduction and comments. We are thrilled to be here and really look forward to this partnership. I'd like to take sort of a flip side question with regard to supply chain, and that is the possibility that not states, but individuals with terrorist intentions could have access to the supplies as accessible as they are, especially using artificial intelligence, and what threat that poses. It was 20 years ago, or not quite 20 years ago, that, or actually more than 20 years ago, I guess I should say, 27 or 8, that I had an anthrax attack in my office by somebody not from a country, but from an individual. And so I think, given technology, given the internet, given AI in particular, given the access to all of those components that make biological threat so serious, I think we have a challenge maybe equal to, if not greater than, the state challenges that you addressed. I'd be curious as to what policies, what efforts we ought to be making in public policy to address that challenge.
Well, thank you very much, Senator Daschle, and also for your leadership. And of course, we all remember the anthrax letters and your important leadership at that time. I think you're right, and I should probably start by saying I'm run a center that does global strategy and security, so I'm a mile wide and an inch deep on many issues, including this one. But my initial thought is that you are right, that there is the danger of individuals also tampering with supply chains in ways that could be damaging to U.S. national security and to public health. And I think the dangers that when we have insecure supply chains that route through our adversaries, those dangers are probably amplified. And we see this maybe with fentanyl as an example, where we see essentially collusion between China and drug traffickers in Latin America and Mexico that are interacting in ways that are dangerous to U.S. public health. So I do think that's one reason why securing supply chains is so important. There is always the possibility of a bad actor in the United States with artificial intelligence or other new technology tampering with things in a way that's dangerous. But I think the secure our supply chains are, we can help to reduce that risk.
Thank you.
I have a question.
Anna, Asha.
No, I don't have a question. No. Dr. Craning is now my new boss. You talk a lot about nuclear
Believe that. We all work for Asha.
oh, how I wish that was true. You speak a lot about nuclear deterrence. One of the issues, though, that we've been discussing is the need for biological weapons deterrence. We haven't seen a lot of that in the literature. It's not really addressed that much, or if it is, it's sort of lumped in with the notion of weapons of mass destruction. And generally, that literature goes back to like the 1980s. Can you just share some thoughts on what you think biological deterrence looks like in this day and age, and what we need to do from a research perspective, or I don't want to say academic, but maybe more esoteric perspective, to beef up that part of our knowledge base in this country? Because I think right now is the time, as we're changing what defense policy is, we need to infuse that back in. But we certainly can't draw on a whole lot from the past.
Thank you, Asha, and thanks also for directing the commission. And we're really happy to have you as part of the team, and have enjoyed working with you and your colleagues over the past month or so, and look forward to many years of collaboration. So a couple of years ago, I was honored to be appointed by the U.S. Congress to a strategic posture commission to review strategic threats to the United States and design an appropriate strategic deterrence posture for that. Biological, chemical space were mentioned in our remit, but the premise of your question is right. We really focused mostly on the nuclear dimension of that challenge, and I do think we need to do more to think about biological deterrence, especially given what the Chinese, the Russians, the Iranians, and the North Koreans may be up to, and that, as I mentioned in the opening, the possibility of a direct great power conflict now seems higher than maybe at any time since the most dangerous moments of the Cold War. I guess I'd say a few things. One, I think our overall deterrence and defense policy contributes to the deterrence of biological threats. If there had been a major war during the Cold War, I think we know that now that the Soviet Union probably would have used biological weapons in the event of a major war, and so by deterring that war, we also prevented biological use. And so I think similarly today, getting our deterrence and defense posture right with Russia, China, Iran, and North Korea can deter them from using biological weapons. The new national security strategy was released last week. We saw Pete Hegseth release or essentially preview the national defense strategy at the Reagan Defense Forum this weekend. And so it does seem like there are the pillars there that could contribute to broader deterrence. Second, nuclear deterrence. As you probably know, the United States has never had a so-called no first use policy. We've always left open the option of using nuclear weapons first. And part of the reason for that has been to deter non-nuclear strategic attacks. So essentially telling an adversary that if they were to use biological weapons, the threat of U.S. nuclear retaliation is on the table. And so not that that would be an immediate or automatic response, but that it is an option, and we wouldn't want to assure dangerous adversaries that they could get away with using biological weapons and not worry about the United States responding with nuclear or other weapons. I guess final thing I would say is deterrence by denial, I think also matters. And one of the things I've learned from you and your team, Asha, is that to some degree, whether a pathogen is released by a hostile actor or by nature or by a lab leak, that a lot of the way that we would respond to it and is the same. And so if we do have effective biodefense policies in place, if our adversaries see that we're resilient, then that would reduce the incentive for them to intentionally launch a biological attack. So essentially a deterrence by denial approach to persuade the adversaries that actually they don't gain very much by attacking us with biological weapons because we are ready.
Okay, thank you.
Congressman Upton?
Well, thank you. And Matt, it's great to be in this new facility. We welcome your participation, your oversight, your umbrella now with our organization. And it's been very nice over the last couple months to actually see you in action. But, you know, this is our first hearing, and so it's really a delight to be here. A couple questions that I have. First of all, thanks for being with us, obviously, today. My notes tell me that the Strategic National Stockpile went from about $13.9 billion during the COVID to, in fiscal year 25, to $980 million. So we are operating in essence under a CR, so I presume that that's going to be for FY26 as well. All of us that, you know, I was in office then along with Anna and others here, Donna, thought we were unprepared. I wouldn't say woefully unprepared, but we caught up pretty quickly, and the Congress reacted pretty fast with PPE funds and a number of things to keep the country afloat. And we relied on China to send masks. I remember I had a corporate citizen in my district actually fly a plane $1 million worth of masks to our local hospitals and some of our facilities, some of their manufacturing facilities around the country, so that the workers would have that safety equipment for them. It seems as though, at least today, that the administration, the current administration, is trying to transfer that through ASPR, transfer those PPE assets today to state and locals and away from the federal government, away from the federal stockpiling. And so maybe that's one of the reasons why we've seen a dramatic decrease in funding to restore those that supply. I'm not sure what the Congress is doing as it relates to the status of the current supply stockpile, but I'm interested to get your thoughts on that, as well as what are other countries doing, particularly now that we're with the Atlantic Council. What has your experience been with your counterparts overseas, particularly in the European Union and in other places, in terms of where are they on stockpile if something happens again? I mean, we're seeing the influx of bird flu, maybe a resurgence, modified version of COVID now, and who knows where that might take us. But where are we today as it relates to what the future might be, and not only in this country, but what other countries might be doing as well, knowing that everybody's screaming for assets?
Well, thanks very much, Congressman, for the question. And on overall resources and on the supply, there are probably other people who will be speaking later today who can get into the status of the supply and the shift towards state and local. But on overall resources, and again, thinking about global geopolitics, it's notable to me that during the Cold War, the United States spent an average of 6 or 7% of our GDP on defense. Now we're spending about 3.5% of GDP on defense. And so if we really believe that we're entering a more dangerous moment than we've been in a long time, and I do believe that with the threats posed by China, Russia, Iran, North Korea, and them increasingly working together, I think we need to increase resources to deal with important national security challenges, including this one. And some people would say, well, the American people won't support that, but I think this is where leadership comes in. And if we have good leaders who stand up in a nonpartisan way and make the case to the American people and say, this is a really important challenge, I need you to support me in this, I think that members of Congress can find the resources. The United States still has the largest, most innovative, dynamic economy on Earth. I think there is also room to learn from our adversaries and, our international allies and vice versa. I mentioned before some of our efforts to work with NATO allies on this issue, but we also do a lot of work in the Indo-Pacific, including with Taiwan. We just had a delegation that returned from Taiwan a few weeks ago, and they've had to deal with challenges. And in some ways, some of our Asian allies may be ahead of us when it comes, because they've experienced things like bird flu that, fortunately we were spared from. So I hope this is something that we can do together, is more international work, learn from our allies, and also share some of our lessons learned.
Thank you.
Good morning. Matthew, very good to see you. Thank you for being here. And let me just echo what Fred said about how thrilled we are to be part of your center and to be working with you, both because your tremendous team that you bring and your tremendous reputation, but also because I think, as Donna said early on, it takes the bio threat and puts it in the landscape, the strategic landscape that you focus on day in and day out. So in that vein, I guess my question would be, just to go very high level, as you know, one of the animating purposes of setting up this commission was just to ring an alarm bell that the bio threat is real. It's going to come home to roost. And obviously, since the establishment of the commission, we've seen COVID-19. And the country and decision makers need to pay attention to it. So once again, at a very high level, do you have a suggestion for purposes of like a strategic approach to raise the concern level about this particular threat in the context of all the other strategic threats that is your sort of the area of your day-to-day existence?
Well, thank you very much, Secretary Weinstein, and as I mentioned, we're really happy to have you all here with us. So I have done a lot of work, as I mentioned, on weapons of mass destruction and nuclear weapons. And as you know, a lot of experts don't like the term weapon of mass destruction because it lumps together a lot of things that are really kind of different: nuclear weapons, biological weapons, chemical weapons, radiological dispersion devices. Nuclear experts like me say that nuclear weapons are a true weapon of mass destruction. Putin or Xi wanted to destroy a society on the other side of the world in 30 minutes or less. Nuclear weapons are really the only way to do that. But I think what sometimes gets mentioned is that biological weapons potentially could even be more deadly than nuclear weapons. If you have an especially virulent, especially deadly biological agent that an adversary produced, that could kill more people. And we saw that COVID-19 was was easy to spread, but and you all are the experts, and I say this with humility, but wasn't as deadly as it could have been. So if you saw something that was deadly, that was also easy to spread, that is something that could be a catastrophic threat to all of humanity. And I think sometimes people forget that, and there's probably more we could do to remind them that this is potentially the most dangerous threat we face, worse than nuclear weapons or climate change or anything else.
Amen. Thank you.
Thank you. Jim?
Sorry to be late. So, and sorry if this question's already been asked, but in the Ukraine-Russia war, is there any indication that Putin has made the nuclear threat? Is there any indication that he has a biological capacity, the inclination to utilize that if push came to shove for him, and if he felt he was in a desperate position?
Well, thank you, and it's a good question. And I think one thing we've seen is that Russia and President Putin is not constrained by international law or international norms, was willing to conduct this brazen attack on a neighbor, really unprovoked attack. And then the Biden administration says there was a moment in October of 2022 where they think Putin was very close to using nuclear weapons. They've publicly said since 50-50 chance. And I think we also know, as I said in my opening remarks, that Russia probably is engaged in dual-use activity and probably could, it already has used biological agents in assassinations, so probably could produce biological weapons. So it seems to me that the nuclear option is more attractive to Putin. He has publicly threatened nuclear weapons since the start of this conflict. Again, reportedly became very close in October of 2022. But given his lack of disregard for international norms, given the high stakes he places on this war in Ukraine and emerging victorious, then I think it's not something that we can discount, that under the right circumstances he might see using biological weapons as attractive.
And for a quick follow-up, I would assume that the Ukrainian military is not very well prepared for that eventuality.
I think that's right. It's amazing what the Ukrainian military has done over the past several years. Many people assumed they would just roll over, and here they are fighting inch for inch. But they are under strain. They need support and weapons from the West. They're facing some manpower difficulties. And so I would guess that they're probably not focused as much on the biological threat as maybe they should be, and maybe that is an area where we could provide assistance.
Thank you very much.
Thank you. Other questions? Tom? Anyone? Let me thank you for an excellent, Anna, oh. Who? Okay, let me ask the ex officios. Do you have questions?
Just one point.
Scooter?
Your excellent answer on BW deterrence.
Is that microphone on, Scooter?
I
Maybe
can't
get a
tell.
little closer to it.
In response to your answer on BW, thanks for the instruction. Deterrence, thank you. Just want to point out that in relation to the question asked earlier, most of those things don't apply to terror groups or individuals.
Yeah, I agree. Thank you.
Matt, since we have a few minutes, can you just talk a little bit about how you see the commission fitting in with the rest of the Scowcroft Center and what your vision is as we've come over here?
Sure, and so the Atlantic Council was founded in 1961 by Dean Acheson, Dean Rusk, Mary Pillsbury Lord, Christian Herter, people who were really present at the creation of the post-World War II U.S.-led order. So we're one of the oldest nonpartisan think tanks in Washington, and now also one of the largest. We've grown a lot over the years, 300 full-time staff, 16 centers covering every major regional and functional area. And truly nonpartisan, like you all are, Republicans and Democrats, and we want to be relevant no matter who's in office. We've been relevant and had access and influence with every administration since Kennedy, and we don't want that to change. And so we've done a lot of good work in a lot of areas: transatlantic security, nuclear deterrence, and as I mentioned, we've done some intermittent work on the bio threat, but not enough, and it is so important, as I indicated before, really one of the few catastrophic threats that we face. And so having the opportunity to essentially join forces with the preeminent organization in Washington and in the world working on biodefense is such an exciting opportunity for us. And so I think the first thing we want to do is to not impede your success, having you continue to do the terrific work you've been doing, having real-world impact, which is something the Atlantic Council is always focused on as well, and so is, again, delighted to see you get your recommendation into the new defense bill. So would love to continue to have that policy impact with you. Also shape the public debate, which is important, and I think those things are related. If you're having impact on public policy, the press turn to you as an authority. And vice versa, if you're shaping the public debate in the press and elsewhere, I think policymakers come to you for your advice. And so that would be first, just continuing the tremendous success you've had. I do think there are opportunities for us to do new things together, given our international connections. As was mentioned before, I could imagine doing more internationally with allies in Europe and in the Indo-Pacific. And then I'm also very excited to learn from you all. And just one physical manifestation of this now is the hearing style setup. First time we've done this at the Atlanta Council, but I think is a powerful setup, maybe a way that we can run our events in the future. And I know we've talked about other innovations as well that you can help bring to us with your radio tours and media tours. So I think there's a real opportunity for us to work together to bring both organizations, and I guess we're one organization now, to new heights.
If I might pursue the international question, is NATO organized on this issue, as far as you can tell?
Yeah, yes, but there's room for improvement. So national governments have offices working on biological issues. NATO has an office working on biological issues. But I do think that there's more that we can do, and we find working with NATO allies every day, and the environment is always changing. They're always looking for outside ideas, and I think this is also an opportunity for us to shape and improve the way NATO coordinates on biological issues.
And since you're observer of the administration as well, is the National Security Council organized in any way?
It's a good question, and
there have been so many shakeups.
Yes, and so I know in Trump 1 there was a lot of reporting about how the Biological Preparedness Office was shut down, and again, I say this with a lot of humility. You all follow this more closely than I do. But a colleague of mine was the senior director for WMD at the NSC, and he said that the office wasn't really shut down. It was merged within his directorate. I know there is a directorate for WMD at the NSC, so I would hope that they're paying attention to the biological threat, but I don't know. It's something we should look into.
Mm-hmm. Yes, go ahead, Tom.
I'm just to follow up on the NATO question. I'm just curious how you look at the national security strategy that was just announced, and what, if any, impact that would have on Atlantic Council's work, and even in this context, our cooperation with NATO as it relates to biodefense.
Yes, well, and it's a good question. And in fact, later today, the Atlantic Council is doing another public event on the national security strategy. And so I'd encourage people to tune into that if they're interested. My take is that the NSS had some good points about Europe, that 1990 it was 25% of global GDP. Now it's only 14% of global GDP. And so Europe does have some competitiveness problems, and a strong Europe is obviously good for Europe, but also good for the United States and transatlantic security. So I think to some degree giving our allies some tough love and saying, hey, we need you to be strong makes sense. I do think, though, that the language was overly harsh and overly critical. It's not the way I would have delivered the message. And I have talked to European allies since, and one ambassador here in Washington said, this seems to be a repeated message now, and so as a European official, it would be irresponsible for me to assume that the United States is just always going to be there for us. We do need to think about taking matters into our own hands. Yet I guess I'm an optimist at heart. I think the transatlantic alliance has been through a lot of challenges in the past, from the Suez crisis, the Iraq war, and I think this is something that we can get through together as well.
Thank you.
Thank you. Thank you very much. And thank you for being such a good initial colleague. We look forward to working with you.
Thank you.
We'll assemble panel 2. And I think, Ken, you've got panel 2?
Yes, I think that's neat. Thanks very much, Matthew.
I don't know whether
so
people are here.
We have Ed here, and Melanie, and Nazak. No. Everybody here? They here? Okay. Do we take a coffee break? You
Yes.
still have some muffins out there.
Yeah. We'll take a break,
Okay.
a 5-minute break.
All right, Ed.
Sorry about that. It should be wasted. Yeah, I don't know what that is. I told them just do a master thing. For instance, I didn't get a master. What you have, I don't have. So you do that here in DC? Well, you were the only person that was supposed to get it.
Hey, dear.
Oh, yes. Yes, he is. He's awesome.
How we got so far ahead.
He's been involved politically, and I think he's done here. He's done a wonderful job of fundraising. He's a fundraiser.
You have to work with someone. Even though he's younger, you want to work with someone.
You know, he is. He really is. It really is good. He's the greatest. I have no issue with him whatsoever. Whenever we've had any trouble whatsoever,
He intervenes.
yeah, and I don't go running down every 32 seconds, and he knows that. So he's done wonderful.
That was great. That was great.
Yeah.
You can sit on the panel right now. but Ken's chairing the next session. Can we ask the speakers to come? Where are they? I'll yield to my colleague, Ken.
Halfway through my muffin, I'm sorry. Okay, good to see everybody. Thank you for being here. All right, I'm honored to introduce the panel 2, which is entitled Allies, Adversaries, and American Manufacturing. And this panel addresses the reality that the U.S. biodefense enterprise relies overwhelmingly on foreign adversaries for critical medical measures or medical supplies. And the COVID-19 pandemic laid bare how heavily the U.S. truly does depend on foreign manufacturing for medical countermeasures. And in fact, at the peak of the crisis, Americans witnessed alarming shortages of basic yet essential medical supplies like masks, gloves, testing swabs, and key drugs, in part because global supply chains flow through China and a few other countries. As Dr. Hart has warned, China's control over the global supply of active pharmaceutical ingredients and their precursors could function as a, quote, nuclear option in trade negotiations. While China has not yet directly threatened to cut off drug exports in America, Chinese state media has explicitly raised that option during times of tension. And in response, the U.S. government has been approaching trade policy in tandem with national security policy. In April this year, the Department of Commerce initiated national security investigations into the import of pharmaceuticals and semiconductors pursuant to Section 232 of the Trade Expansion Act, which authorizes the Department of Commerce to investigate the national security implications of imported products. Solutions emerging from those investigations, such as tariffs, quotas, or other trade measures, could represent a fundamental shift in U.S. industrial policy for medicine. In addition, this geopolitical threat is escalating beyond physical supply chains to include the exploitation and strategic use of biological data. China is heavily pushing to acquire American healthcare, genomics, and agricultural data in what some are referring to as a biological space race, a threat which represents a new frontier in biological warfare. To discuss these issues, we have a blue chip panel of 3 experts, including the following: the Honorable Nazak Nikatar, who is a partner at Wiley Ryan LLP. She's the former Assistant Secretary for Industry and Analysis at the International Trade Administration and the former Undersecretary for Industry and Security at the Bureau of Industry and Security within the Commerce Department. Melanie Hart is the Senior Director of the Global China Hub at the Atlantic Council. Is the Senior Director of the Global China Hub at the Atlantic Council and the former advisor for China in the Office of the Undersecretary for Economic Growth, Energy, and the Environment within the State Department. And Ed Yu is the founder and principal of EHY Consulting and former supervisory special agent at the FBI, also a longtime supporter of the Commission, and we appreciate his being here to share his expertise as we appreciate the other panel members. So with that, start with you, if we may. Just go from the right to the left to with the Nazak.
Yes, thank you, and thank you for holding this really important discussion. For purposes of what I'm going to talk about, when I refer to active pharmaceutical ingredients and then the pharmaceuticals generally, I'm going to refer to small molecule drugs. The U.S. industry on large molecule biologics is actually pretty healthy. We represent, more than 50% of the world's large molecule drug production, and that share, as the global growth in that sector is growing, the America's share is growing significantly too. But on the small molecule drugs, active pharmaceutical ingredients and their precursor chemicals, obviously we know are essential to the health and welfare of the American people. APIs are the basic building blocks of all medication used to treat every American, and therefore critical to U.S. national security and the prosperity of Americans and the American economy. It's therefore imperative that the United States build and maintain a resilient manufacturing supply chain for the small molecule drugs, API, the precursors, and the pharmacological products which contain them. The United States currently produces some medication, and American companies maintain the intellectual property to manufacture a broad range of API and precursor chemicals. Yet market manipulation, cartel price-fixing behavior, and other predatory economic practices by China, namely, but other countries as well, have eroded the pharmaceutical manufacturing base in the United States over the past 30 years. A single foreign country, China, virtually holds all of the precursor chemical manufacturing capacity globally, and 2 foreign countries control the vast majority of the contracted manufacturing organizations that make these APIs for our medication supply chain. These countries are not in close proximity to the United States and often act in ways that undermine U.S. economic and national security interests. Thus, the United States' continued reliance on these countries and their supply chains pose a direct threat to the United States. The current status necessitates immediate action under the Section 232 of the Trade Expansion Act to limit imports of the small molecule drugs, of their APIs, of the precursor chemicals, and their derivative products, and the derivative products, which are the pharmaceutical drugs that contain them, because of the impact on national security. I want to talk about some recommendations that are really low-hanging fruit, but the U.S. government really needs to get its act. If we're going to do this, we really need to get our act together. First, the Federal Drug Administration has a list of sort of the drugs that we need in the APIs. There's absolutely no reason why, when I first started my job in the U.S. government, my job was to survey the domestic biologics industry. It was the first thing I ever did in the U.S. government. These DPA, we issued surveys to 3,000 companies. The U.S. government can, and that was 25 plus years ago, the U.S. government can now issue these Defense Production Act surveys, compulsory survey authority. Companies must respond to figure out, to chemical companies, to pharmaceutical companies, what we have in the United States that's in close proximity to determine what can you produce now, what can you produce in a time of crisis, what is the lead time, and how much money will it take? So we actually have a concrete list of what we need to solve for, rather than just running around like chicken with our head cut off, not knowing what we're doing. My next recommendation is that to the extent that it's very much the case that that foreign predatory practices have material retardation is a term of art and trade, have materially retarded the growth of the domestic industries. We need to start limiting imports immediately, commensurate with the growth of the domestic industry, and we need to invest in the domestic industry. But if you don't do something now, cheap prices will prevent investment in the sectors we need and the companies we need to grow the manufacturing base. Another recommendation is that all imported medication into the United States should have on the label the full supply chain, where every API comes from, where every API precursor comes from, so consumers can exercise their choice to buy the drugs that they need. We need to really think about outside the U.S. government, third-party regulators who will be working on behalf of the U.S. government to help do some of the testing and the certification we need so the FDA doesn't have such a huge backlog. We need to, as as costs increase, this is my final recommendation, as costs increase, as we put import restrictions in place and the domestic industry grows, we really need to use something similar to food stamps, like vouchers for low-income communities. We're going to be collecting tariff. Provide some of those to the low-income communities, hospitals, et cetera, like food stamps, like vouchers, so they can have access to affordable medicine while we get to an equilibrium and our industries can scale and bring costs down. Thank you.
Okay, thank you very much. Melanie, would you like to go?
Sure.
Looks like Ed's passing to you.
Yeah. So I'll make 3 key points this morning to start us off. First, U.S.-China pharmaceutical supply chains are the inverse of most of our tech relationships with China and most inverse of other sectors, in that the low-tech side, sourcing ingredients and APIs and final products, is our biggest near-term risk. The higher tech side, partnering with China on drug development, is less existential at present, but also something where we need to be focusing our attention. On the lower tech side, China makes drug components and end products cheaper than most other suppliers, so we've become heavily dependent on China for multiple drugs. We have to be aware that Xi Jinping has stated the whole point of putting China at the center of global supply chains is so that Beijing can use those to yank the chain on other nations and cut them off to bring other nations to heel. We just saw this play out in rare earths. When China cut the United States off from rare earths, Ford had to shut down production for a week. That's a serious outcome, but hospitals shutting down for a week is an entirely other level. We cannot allow that to happen. So taking action immediately on the lower tech side of the supply chain, getting generics, statins, antibiotics. This is not fly to the moon stuff. This is the drugs that Americans depend on a daily basis. Having reliability in those supply chains is absolutely critical. On the higher tech side, we are also increasingly dependent on China for drug development. To develop a drug, you need to conduct a trial. To conduct a trial, you need to have patients who are participating in the trials. China has 1 billion more people than we do. They're getting cancer and Alzheimer's and other diseases on rates comparable with Americans. Most of them, unlike Americans, when they sign up for a trial, that isn't their 3rd or 4th option, that's their first option. So from an FDA perspective, if this drug cures someone's cancer, that was the only intervention that you had in that case. So that gives them very high quality data for determining, does it work and is it safe for Americans? Right now, we need access to that population, and that's saving American lives. There's a little space there for cooperation, but we don't want to become too dependent in that area either over time. Right now, we don't have a good alternative to China for trials and drug development. Everywhere else is slower. India also has a big patient population, but their healthcare system cannot perform at the same standard to meet the same US healthcare standards, such that we can take that data and use it with the FDA for the American market. We could engage India to help bring their system up to standard to provide an alternative. So the urgent priority is making sure Americans have access to antibiotics, to statins, to other products who are overly dependent on China. We should keep an eye on that longer term risk as well. Second, reducing our most existential risk, that supply chain, drugs and ingredients risk, requires smart investments across the supply chain. We cannot do it alone. There are too many drugs that Americans rely on. We might think about the kinds of drugs that would be critical to respond to an epidemic, like antibiotics. But guess what? We're also dependent on China for statins, for the vitamin mix that you use to make infant formula. There's a wide range of products. It is very difficult and costly to make all of them in the United States. But if we partner with India, if India is building up capacity on one drug, we can focus elsewhere. If Europe is building up capacity on certain key ingredients, we can leverage those and focus elsewhere. We have to have an ally and partner approach. And we have to recognize that price and reliability are trade-offs. Right now, our entire healthcare system prioritizes price. There are caps on the price that Medicare, that insurance will pay for these drugs, and they're based on the China price. If you don't want the China drug, then you can't have Medicare locked into the China price. To do what my co-panelist is suggesting, we have to pay for it, right? Americans understand that if we want to be safe militarily, we have to pay for weapons. We have to pay for the men and women in the armed forces. We have to bring about an understanding that if you want to be safe on the medical side, then you have to find ways to pay to make it somewhere other than China. It's safety or the China price. It's a pretty clear choice. And then third and finally, we're at an inflection point in US-China biotech competition whereby China is within striking distance of reaching parity with the United States and surpassing us. We absolutely do not have even a smidge of margin in this competition to be defunding NIH, any amount of science, research, and development. We need everything we've got to stay ahead or even with China. And I'll give 2 examples. First, Sloan Kettering is doing some amazing research in figuring out how when patients have pancreatic cancer, they can operate on that cancer and then take the tumor itself and use it to develop an mRNA vaccine against that individual person's tumor and then vaccinate that patient against the cancer that they took out of that patient's body to prevent it from coming back. That takes a lot of money. You have an entire team in service of one patient, an entire manufacturing process to develop an mRNA vaccine for that patient's cancer. But it can stop pancreatic cancer from coming back. And we don't have a lot of other options that can do that. That's not a really marketable solution right now. That costs quite a lot of money on the front end to get to the point where we can make that at scale much cheaper, where it can be deployed across the United States. That's why we need federal science funding. If we don't do it, China will do it, and we will all be flying to China to get cancer treatment. And guess what? Beijing decides who gets a visa and who doesn't. So that means American citizens will be self-censoring themselves, doing things to stay on China's good side so that they can fly over and have access to the kind of innovative treatments that we have at Sloan Kettering and other US centers right now. And then just my final point, China is combining AI and robotics with biotech in ways that are enabling them to use brute force to surge ahead of the United States in research and development of new drugs. A lot of our new medicines right now are coming from the mapping of the animal genome. Humanity has only mapped a small percentage of animal genome, and we're finding that as we do more of this gene mapping, we find new drugs. GLP-1, the obesity drug, came from mapping of the Gila monster's genome. China has massive warehouse factories of robots doing around-the-clock, 24 hours a day, biological research, and they turn those data points into an AI model. They can map genomes at scale. That will enable them to discover and develop drugs at paces that we currently cannot match. I hear from multiple pharmaceutical companies that the reason they're going to China and acquiring assets is because they can't find them here. So there are already areas of biotech where we're behind and China's ahead. And that's why our companies are going over and paying billions of dollars to access the science. We don't have the margin to gut the funding. We have to be racing faster. That's it for me.
Good morning. I just want to thank the Commission for inviting me to come back and present to you all. Then there was a reason why I wanted to come up third in that I do want to leave the bottom line up front to pose to you that because we're focusing on supply chains, we really do need to do several things first. One, expand the threat landscape. It's more than just biological weapons. It's more than just bioterrorism. And fundamentally, too, I want to leave with you that bioeconomic security equals critical infrastructure security equals economic security equals national security. So it is not just a public health threat. It is absolutely a strategic economic threat that we are facing. And so I want to leave you some case studies that I think we are worse off since COVID-19, despite the fact that the government poured billions of dollars in the COVID response. So as we mentioned, looking at artificial intelligence, and China came out with DeepSeek, we need to know that AI is nothing without data. And as was mentioned, China is on a tear in hoovering up data all around the world, either illicitly or legitimately, through contracts, by playing by our game, by offering a lower price point in multiple services. Congressman Eshu, I want to acknowledge you because you tried to pass legislation to protect genetic data, looking at also protecting the synthesis of DNA. However, we need to see where we are right now, that just a couple of years ago when ChatGPT-4 rolled out and we had the likes of Elon Musk and others saying, wow, we're reigning in the end of humanity, and we're still debating that. Quietly on the other side in China, Baidu Research, their largest internet firm, they rolled out their large language model, AI, and one of the first things they did is they trained their AI on our COVID mRNA vaccine sequence. And within 11 minutes, their AI came up with a new sequence, and when they manufactured it, it turned out to be 128 times more stable than our COVID mRNA vaccine. And so it did not require the same extreme cold temperatures for shipping and storing. And it also meant that it had a 4 times more increased antibody response. And so along those lines, in the last intervening years since COVID, China has strategically invested not just in design, but in contract manufacturing. Across the globe, they have invested in contract manufacturing organizations, research and development manufacturing organizations, end-to-end, from data acquisition to AI to design to mass production. They are now better postured to respond to a potential pandemic or other large-scale event. And we already experienced what happened to us when we went through COVID, where we couldn't even get masks because we had completely outsourced PPE production. Well, it's much more than that now. And another angle, too, is that with all the data that they have, with the infrastructure investments, with the technology and talent acquisition, it's not just looking at our current drug supply chains, but looking at the future. Because as it stands right now, not only have they invested in infrastructure, but they've also invested in regulatory reform. They have completely aligned themselves with the International Council for Harmonization for Chemicals, Medicines, and Clinical Trials. They have streamlined their own Chinese FDA review process from 60 days to 30 days, so it's aligned with our FDA. And what this is translated into is, as we speak right now, there are more CAR T cell therapy clinical trials being sponsored by China than anybody else in the world. And they're not doing it just in China, they're doing it here. They're doing it abroad because they are playing by the rules. And so if you think about it, we cannot make antibiotics now to save ourselves to completely outsource it to China. As was mentioned, most of our generics come from China. Most of the active pharmaceutical ingredients come from China or India. But play it out. If we are now also looking at not just chemical-based therapeutics, but now cell-based therapeutic, which is the holy grail for personal treatments, for precision medicine, and they own that high ground, that's everything. And so it's not just about supply chain dependencies. It's critical infrastructure strategic advantage, but also, theoretically speaking, we went through so much effort to protect ourselves, but it's not just playing defense. I firmly believe that we are amidst of a global biotechnology space race. You do not win a space race by playing defense all the time. You do not play it by using export control or CFIUS all the time. It is making strategic investments, is doing better analysis on what constitutes a biological threat risk. It doesn't help in the interim that, despite the fact, Senator, that the anthrax mailings, and because of the 9/11 Commission, Dumdy Commission, that was the genesis for the FBI's Weapons of Mass Destruction Directive, which I dedicated 15 years of my FBI career to, that has since been folded. We closed the Department of Homeland Security Center for Weapons of Mass Destruction, countering WMD. ODNI shuttered the Center for Counterproliferation and Biosecurity. So the part of the government that would address biological threats has been curtailed. The thin blue line now is basically, before retiring, I was part of the FBI's National Counterterrorism Task Force, which was an interagency effort to address issues like we're discussing today. We still have a few weapons of mass destruction coordinators at the FBI field office level, but that thin blue line is getting even thinner. But we also really need to understand what is China's strategic realm, because the tagline, the punchline that I use is that it's not the bioweapon. It's that because of our short-sightedness, we're going to wake up one day and realize we've just become healthcare crack addicts and China's become our pusher. And the nightmare scenario is that what happens if the shining examples of biotech advances is not coming from Silicon Valley or Cambridge, Massachusetts, it's coming from Shanghai and Shenzhen. And what does that look like for us strategically? What does that look like for economically? What does that look like for us from a national security perspective? And I'm happy to go into further in depth, but I welcome any questions and comments you might have.
Okay, well, I'm always on the lookout for good phraseology that really captures the essence of a point. And healthcare, we are healthcare crack addicts and China is the pusher. that ranks pretty high up there. That's a good expression, so I'll keep that one. If you don't mind, I'll steal it for myself. So let me start with you, if I could, Ed. You mentioned China's data acquisition efforts, and just in your current role, but also in your former role as an FBI agent in this space, what are some of the efforts that you've seen China undertake, whether it's trade secret theft, economic espionage, and the like, that has targeted data that they want in order to build up their bio capabilities?
No, sure. So it's China's illicit acquisition of biological data is pretty well documented. I mean, that's the reason why the FBI is as busy as it is. But what I do want to focus on is what's happening in plain view, but we're just not paying attention to it. So in the intervening decade or so, China has invested in commercial or clinical companies that do DNA sequencing, for example, or diagnostic testing. These companies are HIPAA compliant. They have obtained Centers for Medicare and Medicaid Services CLIA CAP accreditation, so they've been certified to do patient clinical diagnostic testing. What's even more salt to the wound is that some of them are even Federal Acquisition Regulation certified, so they can actually put in bids for government contracts. So what this is translated into is that across the country, even across the globe, you have entities, U.S. hospitals, public health labs, clinics, universities, companies, even state and federal government agencies contracting with these firms and sending over biopsies, clinical samples, blood samples, pediatric samples, research samples. And these Chinese firms process them, and our clinicians and scientists get that information back. But at the end of the day, these very same companies, because they are Chinese, they are subject to China's national security laws, which requires them to be able to provide the data if the Chinese government determines that there's a national security need. So unfortunately, a lot of our companies, even if you think about from a hospital standpoint, they just don't know any better. They are not privy to the same national security risks that we all are, unfortunately, painfully aware of. So whether it's because they can offer a compelling low price point, but absolutely they are playing by our rules sometimes better than we are ourselves. They have insinuated themselves not only in the US, but they satisfy European Medical Agency requirements, and so they have even non-invasive prenatal test kits that have been deployed across European countries, so even pregnant moms are providing their samples. We just are not understanding the issue.
May I add a few
please.
points? One of the large Chinese, and I'm sure this is across the board in China, CDMOs, in order to contract manufacture for U.S. companies, they require the U.S. companies to deliver their IP to them, to mass produce for them. That's one thing. I used to run CFIUS at the Commerce Department. I will tell you that CFIUS also clears transactions without adequately looking at the national security threats, does not do a good enough job bringing in non-notified transactions that should be notified to CFIUS. They just fly by night, nobody notices them, and nobody sometimes is looking for them, and then where they are flagged, CFIUS just refuses to look at them. Then you've got this growing issue with Chinese companies pretending like they're going to invest in American companies, forcing the companies to give up all their IP, trade secret, whatever, and then the investment never goes anywhere. And then all of this broad landscape with CFIUS legal jurisdiction to this day does not exist. Yet the president, either Congress legislates or the president through IEPA. IEPA is built for this, to protect against national security threats when Congress hasn't moved yet. So the president can even use IEPA to close those gaps in CFIUS until Congress introduces legislation. That has not been done yet. And the final point is, you mentioned it's not just CFIUS, it's not just export controls. The Chinese are everywhere. It's like I compare them to an octopus with their tentacles and everywhere. So we really need comprehensive legal solutions, and export controls need to do better. And the crown jewel in the U.S. government on technology, which the government really doesn't access, is national labs. They know what's happening. They know where the innovations are. They know who's participating, and they can help the government control technology better so we don't have, so where export control fails, for example, we still have the buffer of export control. I mean, where CFIUS fails, we still have the buffer of export controls.
If I could follow on, thank you for that, follow on your comments about CFIUS. your characterization of CFIUS as being sort of too permissive, is that across the board, or is it particularly are you saying that specifically as to the biospace?
It's permissive across the board, but over the time that I was running CFIUS at Commerce from 2018 to 2021, we saw more and more and more transactions in the biologic space and the pharmaceutical space. The Chinese are after that sector. And we either cleared it, we cleared with mitigation. Mitigation essentially means, oh, China, now you've invested in our company, adhere to our laws and don't do X, Y, and Z. While China has an anti-foreign sanctions law and the national security laws, but the anti-foreign sanctions law that says you can't abide by any laws that undermine the CCP's interests, right? You have a conflict of interest. You cannot fundamentally have a mitigation agreement with a Chinese entity when their Chinese laws are forcing you to break the terms of the mitigation agreement. So we clear, we approve with mitigation, and then a lot of times there's non-notifieds and everybody just looks the other way. But it's across the board with China, but in the pharmaceutical space, the transactions have steadily increased.
Okay. Sure.
So part of the problem is that when it comes to biothreats, it goes back to my plea to really need to expand the definition and the scope of what constitutes a biological threat, because even with CFIUS, I'm a big fan of the process, but that's a pretty big hammer and you're trying to search for everything else to be a nail. The issue, though, is that when it comes to export control or dual use, it's looking at a military application of biology. So again, it's looking at the militarization or the weaponization of bio. Everything I articulate is the weaponization of their economy. And by translation, it's also even increasing our supply chain dependencies. That's not covered under a military kind of review, unfortunately. So that goes back to, we really need to go back and redefine how do we scope what constitutes a biological threat. Do we focus on, animal and human health, the virus, the bacteria? Of course we need to. But if that's the only scoping of what constitutes a threat, and without understanding things like CAR T cell therapy, precision agriculture, biomanufacturing, all of which have huge consequential impact on our critical infrastructure, if that's not being incorporated, then we are absolutely missing out.
That's why we need multiple solutions, because not one tool in the tool chest is perfect, right? We need a lot.
Okay. I'm going to abuse my moderator prerogative and ask one more question, Melanie. You mentioned China yanking the chain with rare earth minerals. Have we seen that in the medical biological space at all, vis-a-vis us or any other country?
We haven't seen that yet. I will say that in my previous job at the State Department, I led our efforts countering Chinese economic coercion toward other countries. And there were cases where that was a big concern, that it might be part of the toolkit that could be played. We haven't seen Beijing go there. They recognize that there's a lot of downside risks to that option. That's why in the quote from Bloomberg, I called it really the nuclear option on the China side. But a couple of years ago, we probably would have said that China yanking the lever on rare earths was a nuclear option. And there are scenarios in which we would see Beijing go to the nuclear option. Taiwan, for example. If we were in a Taiwan contingency, nothing would be off the table for Beijing. And personally, I don't think we should be putting American lives at risk and gambling on whether or not Xi Jinping is going to yank that lever.
Okay, thank you. Ed?
Actually, that chain is being yanked as we speak, but not in a way that I think we fully appreciate. It is bio related. It's our agriculture sector. Okay. That we're already seeing that because of the tariffs, that the Chinese government has stopped all purchases of soy. A lot of our farmers are on the ropes right now. And yes, there is some promise of some purchase, but it's only a fraction of what they were buying before. But the problem is that we're not paying attention to the fact that in the intervening years, China has heavily invested in precision agriculture. That's genetically engineering next generation GMO crops that are heat resistant, drought resistant, disease resistant, looking at improving logistics. As we speak, last year, President Xi and President Putin closed on a deal, agricultural deal, 12 years, $28 billion to sell 70 million metric tons of Russian agricultural goods to China. China is building out the infrastructure for Argentina and Brazil to get their soy and corn. So while they may promise for, buying some more of the U.S. agricultural goods, that remains to be seen. The White House just announced that they're providing some subsidies to help our farm sector. We're not going to claw that back. The China's investment in biotech is absolutely playing out into the Southern Hemisphere countries, the BRICS Alliance members that have large-scale biomass and agricultural aspects. And the reason why I say the other elements of innovation is that wouldn't it have been nice if we had a large-scale biomanufacturing capacity here in the US, if we had biofoundries dotting the country, all that sudden surplus of sorghum, corn, soy, wheat, if we can then have transitioned that into our own biomanufacturing capabilities, we would be much better off right now, but right now we're not doing either of those correctly.
Okay. Oh, yep.
Sorry, the agriculture community right now is really freaked out that the vitamins that they use for their products are all coming from China, and it's just, they've been screaming into the wind about the introduction of pathogens into our food supply chain. And then when we all get sick and we need medicine from China, China can easily not use an excuse like, I'm not going to give it to you, but they're really good spin masters. They can say, oh, right now we can't really ramp up production. We have to prioritize our own people. Sorry, you're not going to get anything. And that's how they're going to play that card.
Okay. Well, this is great. Thanks for all your input. This is a hot bench. That's great. Okay. Let me see who else has questions. Secretary Shalala?
Why don't we start with our newest commissioner?
Oh, I'm sorry.
That's all right.
Anna?
Thank you, Ken. Well, first, let me say to the commission what an honor it is to be a part of this work and to join you in it. To the audience that's here today, I have worked with each person, I think, that is a part of this commission, and it is kind of a celebration of old Energy and Commerce Committee members, but really an honor to be here. And I thank the Atlantic Council for placing the commission under their considerable umbrella, and to each one of you that have testified today, thank you for this highly instructive testimony that you've given to us. An issue that I delved into as a member of Congress, when I first learned about it, I thought this really cannot be the case, that we would be so vulnerable to China in terms of API. The doctors at Stanford University Hospital, in a meeting with them when I was doing some work to prepare for legislation to try to address the issue, said that of the emergency carts that they have in every single hospital and the top 12 or 14 drugs, they would all be wiped out if China chose to pull this rug out from underneath us. We had hearings on the issue. It was an issue that every single member of Congress, it didn't matter where they were on the political, ideological spectrum, we were not aware of it at all, not even as a member of the House Intelligence Committee, was never made aware of it, which I still think is really quite startling, because this is a real threat to our country. So now you've enlarged on that and spoken about the challenges, the huge challenges we have with China on this. Why is it that there is not a developing American market for active pharmaceutical ingredients? What is it that is hindering us? Is it a lack of good government policy? Is it policy that's not attracting investment? Is it too easy to just depend on this and say China's never going to exercise, pulling the rug out from it? If they do, how long would we last without API? How long would we last? A month? 6 weeks? Less than that? So, whomever would like to address my
I can start on the sort of
questions.
trade. So I've been a trade supply chain lawyer for 25 years, and this notion of material retardation, right? When low global prices actually prevent market entry, right? Or Rosemary Gibson has in her book China RX, she's talked about sort of the penicillin example, where in 2004 we had production, the Chinese crashed global market. Competitors left the industry and then it just gained monopoly, right? That's essentially what China does. It crashes global prices. Everybody gets out of the market. That's not a non-market economy like China. And in trade, we have a
Actually happened?
Yeah, that actually happened in 2004. That's essentially, having covered like virtually every sector, that's really China's playbook. They will crash global prices so that competitors leave and then they grab monopoly. And in the trade world, we call that material retardation, when you actually can't re-enter the market, or you can't enter the market to begin with because the prices are so low. And so what we have decades of evidence on the US government, how the government has solved for that, is that it's introduced tariffs on imports to kind of create a level playing field, so that now there is financial incentive for market entrance.
Are there tariffs on API?
Not yet, because we are waiting for the Section 232 investigation. And from what the president has said publicly is that he's just going to exclude generics. Oh my gosh, that's where we need the focus on. And the tariffs don't have to be 100% overnight. They can, the president can tomorrow, this is what I would do, announce a tariff schedule that slowly gives everybody advance warning right now that tariffs are going to be ratcheted up over time. So investors in the industry now sees a path forward and has the ability to invest in domestic capacity. If we need to accelerate domestic build out, the government can use, awards, loans, loan guarantees to help that. But generally, without that, you do see the market grow domestically when the government moves in that direction.
Let me just ask a question that follows up with that. Is the administration expected to make their decision before the end of this month? Right?
They are supposed to complete the Section 232 investigation report by December 27th. But that they don't need to make the report public immediately, eventually, whenever that happens. And then in first quarter next year, we'll see a sort of a proclamation by the president, and something most likely given the way things do. But the president can also defer imposing import restrictions altogether. And the import restrictions actually can be, tariffs, quotas, tariff quotas. They can also be price floors. They can say for China, for India, for whatever countries, you cannot enter these goods for anything less than this price level, right? So there's so many mechanisms that the president can use to level the playing field. But the statute also allows the president 180 days to not take action and try to negotiate his way out of this. So we need immediate action right now to really encourage those domestic investments. And I frankly don't know if we're going to see those measures to level the playing field, and whether they're going to be trying to level the playing field for what matters, which is really the generics and some of the small molecule drugs.
Okay, Donna?
Did maybe
Go
Dr.
ahead.
Yu or Dr. Hart want to?
Go ahead.
So, in many ways, although I bash China because they sort of deserve it, but then at the same time, I'm also very jealous of them because I think they fully recognize the strategic importance of the biotechnology and the bioeconomy. And you just look at, they telegraph what their interests are. So you look at their Healthy China 2050 strategy, their the China Standards 2035, where they're actually looking at developing the future standards in the biotech space. If you influence standards, you influence global markets. And so, the three areas that they're already focusing on right out the gate is AI, quantum, and biotech. That should tell us something. And I would bet good money, or what's left of my retirement, that their 15th five-year plan, biotechnology is probably going to be in one of the top 5 priorities for them. They understand what's at stake. So the flip side for us is that we need that sort of guidance. I'm very pleased to see that Congress has established the Biotech Caucus. There's some legislation, some of which you were initiated. Hopefully some of that, but it's got to be more than just playing defense and protection. It's also looking at strategic investments. And if I may just kind of give a quick anecdote, that we really need to go beyond just looking at it from a strategic national stockpile, which is incredibly inherently reactive, very expensive. It is kind of stuck in time, but I had the honor of supporting Operation Warp Speed because I was loaned out to Department of Health and Human Services, and At the time, before the mRNA vaccines came out, we were dependent on the Novavax vaccine, and that was dependent on an adjuvant, an additive that triggers the immune response. It's a saponin that came from a very specific source. It's a Brazilian soap bark tree. There was a limited supply, and at the time, there was a lot of political unrest, that there was real concern that what they had collected would actually literally go up in smoke, and that would have been a huge threat to that particular vaccine. There were numerous white papers saying, why we don't use synthetic biology to reprogram basically baker's yeast to make the precursors for this particular additive. And if we did so, we could deputize all the microbreweries in the country and have them scale up production. But it just showcases that there was a missed opportunity to leverage things like the Defense Production Act to really invest in the infrastructure for biomanufacturing that in the long run could be kept warm, that if you had universities or startups utilizing these spaces to go from proof of concept to initial scale up, that's a huge de-risking, that's a huge decrease in capital investments. It really flourishes innovation, but that doesn't happen unless you have some guidance and leadership from the government level with some strategic investments. There is some of that happening. I point you to, if you have the time, to look at the Commonwealth of Virginia. They launched the Alliance for Building Better Medicines. It is absolutely a public-private partnership. In fact, some of the pharmaceutical companies just recently announced, I think it was $120 million initial investment to look at reshoring medicine production here in the US. It's a great proof of concept, but boy, do we need to scale that up and much more broadly, right quick.
And one thing you asked about policy failure. I think it is very much policy failure. Low-hanging fruit is labeling requirements. There's absolutely no reason why everything that I get from the pharmacy, whether I need a prescription or just get like vitamins off the pharmacy shelf, shouldn't tell me where all of my ingredients come from. So the American consumer can exercise their purchasing power to make the right decision. I don't think anybody in Congress is going to be against transparency. So why we don't have mandatory labeling requirements like that, and as a former U.S. government official who used to audit foreign companies for the government, it's a simple auditing. Don't let anybody tell you it's that complex. And then, as my co-panelists talked about, so we need to pay for it. Let me just remind everybody, we pay for the better quality things all the time. Every time we go to a store, every time you go to the grocery store, you make that choice. Do I buy the really cheap stuff that I know it's full of fat or it's going to fall apart tomorrow, or do I buy the better quality stuff? We're already doing it. It's not that hard of a choice to make.
Dr. Hart, did you want to comment?
Yeah, just briefly, we need an innovation plan for this sector. China has one. And we risk, without that, we're kind of shooting blindly into the dark. Let's try some tariffs over here. Let's throw some investment over here. China has a comprehensive innovation plan. It was part of Made in China 2025. We're now in 2025. So the clock has kind of run out on us being able to just ride on the coattails of former US greatness and success. We have to get serious in this sector. That requires investment. That requires actually having a plan and running faster, as well as having strategic use of tariffs and other tools.
Thank you very much.
I'd like to ask about clinical trials, because FDA has been very wary about Chinese clinical trials because of the lack of diversity of the population. And in fact, I can't think of a drug that FDA has approved just based on a non-American clinical trial. They usually require, if they've got a lot of data from Europe or even from China, that we do American clinical trials, which obviously slow down the process. And FDA has pretty rigorous standards in every administration about how those clinical trials are conducted. So I guess I'm less worried about the Chinese clinical trials. While they have volume, that is, they have a big population, they don't have the kind of diversity that we normally require in FDA approvals for clinical trials. Now, it's not that FDA doesn't take into account. They obviously look at the Chinese clinical trials information, and they look at the Europeans and wherever else clinical trials were provided. what is more worrisome is if the Chinese are also doing clinical trials in the United States that they're paying for, which would duplicate what they're doing there. Do you have information on that and on the mix of the clinical trials that are being presented to to the FDA?
So the drugs are going to China first. So the first, second phase trials are happening in China before they come to the United States because they can happen there much faster.
Yeah, we've always sent American manufacturers or pharmaceuticals have always gone to Europe first.
Now they go to China first. Yeah, because Europe doesn't have the ability to move as quickly across borders with the same size as population.
So they go to China first, but then they have to duplicate that, right?
So the FDA generally requires drugs to do a final trial in the United States before it goes to market so that they have the more heterogeneous population. So one example, there was a Chinese company late 2024, around this time last year, that came out with a liver cancer drug that seemed to be outperforming the major US competitor, and markets got very excited. The trials in China were outperforming the US drug, and that there was a longer timeline to the cancer reoccurrence. When they ran that same trial on a more heterogeneous US population, they did not get the same data. The US drug was performing better, but that was just the first out of the gate. We will see more drugs developing where the ones developed in China are performing better in the U.S. market.
But the difficulty is the diversity of the population, which is a real restriction.
The homogeneous population is a restriction, but China can go overseas too, right? So that it's not the case that just because X% of the population in the borders of mainland China or of Han Chinese descent, that doesn't mean that we have a wall of superiority for clinical trials. We have to be running faster and finding more options ourselves, because it is also a numbers game. In the United States, if you've been through, I've had family members that have dealt with cancer, it's very hard to find out where the trials are even happening. So I hear a lot of complaints from the R&D leads in the United States. You can have a drug in the United States, but good luck finding the patient population that you need that fits your specific needs. For example, to have the kind of pancreatic cancer that Sloan Kettering is working on that is both operable and fits checks the boxes for the trial they have going on right now for that mRNA vaccine. In China, they have 1 billion more people than we do. They can get that trial together faster. So if you take China out of the equation right now, Americans, new cancer drugs, new immunological treatments, we get a 1-year delay. And there are people who die. So that is a dependence. Right now, if that saves an American life, let's do that. But we should have our eye on the longer term on having more options for running those trials.
But we do have an emergency process through FDA.
Sure, but
when clinical trials aren't completed.
Sure, but I think we want to have more breadth than we would, if we have an emergency, great. But we want to have more breadth of trials. We want the average drug that saves lives and is safe to reach patients faster. That saves lives. And so we need to be innovative and creative about doing that. Right now, that means going to China. Over the longer term, that's a concern that becomes our next dependency. So let's be looking at India. We can work with Europe and do some more regulatory harmonization so that we can do more trials faster in Europe. We can work in the United States. We could have, for example, in the United States, centralized databases where patients themselves can call and find out where trials are happening and get engaged, cutting some of the middlemen out of that transaction. Lots of solutions there. Right now, we aren't following any of them.
If I may follow up, you're also, it goes back to my opening statements that we really need to reframe what the playing field is. In that, yes, China has a huge homogeneous population, but with their latest implementation of national security and privacy laws, we don't see any of that data. There is no reciprocity. So if they're able to tap into data from all around the world, as it was mentioned, and yet retain theirs, that's a enormous, multifaceted, diverse database that they're developing, which we do not have access to, which get from an analytics, from an AI standpoint, that's a huge advantage. But it's also changed too, is that historically it's always been the large pharma hoping to break into the Chinese market to gain access to those 1.4 billion potential customers. What I'm starting to see right now is that the tables have turned. That because of their investment in infrastructure and technology and their regulatory reform, they have now fast-tracked it. You're starting to see Chinese companies, startups, coming up with new INDs, and because they're playing by our rules, they are actually not only working with the CDMOs, but actually licensing. Our companies are licensing it to bring their products to our markets for clinical trial production and application, and therefore bringing it to our markets while retaining domestic control. So the tables have flipped. And we're starting to see more and more of that. You're seeing an explosion of Chinese investigative new drugs coming to market. And it was already mentioned, we are doing the wrong things. We are not only cutting back on the security measures on where we address bio threats, we're not assessing bio threats adequately in light of what's happening from a biotech standpoint beyond the bioweapon. But then also we're not looking at what does this look like from a market share standpoint. So if Chinese firms are playing by our rules, getting access to clinical trials, not only within China, but then abroad, and we're not paying attention to, well, it's not just about our products or IP going to China, but think it through. If we are doing clinical trials here on US patients and is sponsored by Chinese entities, that clinical trial data is eventually going to go back to China as well. So this is way more than just our genetic data that's going to be potentially going back to China. It's sensitive, intimate clinical information on our patient population that may potentially be going back to China. And the FDA, yes, they are important in this place, but at the same time, their primary mission is patient safety. They're not in a position to look at economic security or national security. But it doesn't mean that they don't have the tools at their disposal. Maybe it's doing a more oversight or a better application integrity protocol investigation, better inspections of those very same Chinese companies that are coming to light that are going to give, Pfizer, AstraZeneca a run for their money in liver cancer treatments. But it goes back to, if we don't have the policy imperatives to make that happen, we're just opening ourselves up to these broader vulnerabilities.
I mean, to me, it's astounding. Just a quick point that we define China as a foreign adversary in statute, yet we're just like, come on, just have all of our data, right? Like, we've got to thread the needle in what our policy is. We're inconsistent.
Are you suggesting that we should, most clinical data is either published or it's submitted to the FDA one way or another. It's always been pretty transparent. So why are we uptight about China getting clinical data?
So I'm happy to weigh it. So we're talking more about patient and genomic data. We could have a data agreement with China whereby we place restrictions on what we share with them. They already place restrictions on what they share with us, but not vice versa. There are creative things we can do to save as many lives as we can while protecting national security. So we could do more, for example, to anonymize the data that we're sharing so that you see as a population, you can look across the population as a whole, but you don't know Melanie Hart's genome looks like X. So if you want to target her, here's that gene map. You can still anonymize the data so that you can share and do cross-border drug development while protecting national security.
Well, we have rules about identifier in HIPAA.
But we can do much more.
And if I may, that kind of goes back to...
We have careful rules in HIPAA that applies to both clinical trials as well as to research.
Madam Secretary, if I may, so it also looks at how we need to be looking at this in a more coordinated fashion. So let me just give you a case study because I had many discussions along these lines. Just for example, it's all context dependent. You can have the same DNA sequence, the very same DNA sequence. If you're providing it as a human subject for volunteering for, say, like the NIH All of Us program, you're going in as a volunteer. It is going to be done for research. It's going to be open. The individual volunteer should be provided the risks. Honestly, the risk is not just re-identification. It's not about anonymization. I don't think privacy exists anymore. It's understanding what is the implications of the value of your data and how it could be, what is potential use case. We are not providing that to the volunteer. Secondly, if you're that very same sequence, if you're providing it as a patient in a clinical setting, then HIPAA applies. But again, at the same time, in this digital age, HIPAA is woefully ancient in looking at when it comes to genetic information. Thirdly, that very same sequence, if you're submitting it as a customer to, like, say, a genealogy company, right, or you want to, like, I want to find out what percent ethnicity I am, or looking at other type of diagnostics, as a customer, those protections don't exist. And for example, that should be something that should be premier on the Federal Trade Commission, looking at what does consumer protections look like in this space. So that very same DNA sequence, depending on the context, has different policies that impact it, and at the same time have national security implications across the board that we are just not assessing appropriately.
Okay. Thank you.
Okay, should I go to Governor Ridge? Governor Ridge, would you have any questions for the panel?
I do have a question. Reading the memo that was prepared for us, our staff identified 700 U.S. medicines are dependent on at least one key ingredient solely sourced from China. This includes common generics that account for approximately 90% of all prescriptions in the United States, which led me to believe whether or not this is a panel that should answer it. Maybe some pharmaceutical CEOs could answer it. If that many medicines are dependent on Chinese infrastructure, that means that it could be turned into a very useful trade war mechanism if China decided not to give us access to those ingredients. Do any of the panel members aware of these key ingredients? Are there alternatives to China to provide this critical ingredient that you're aware of? I guess I'd probably have to tell you what those medicines are.
My understanding is that the FDA has the list of those ingredients. From everybody I've talked to, the FDA has sort of the master list. And so I've been an advocate of the U.S. government surveying all American companies and seeing what can they produce right now that China can, because as we all know, China manipulates markets and eradicates competitors from the market. So we take that FDA master list, we survey all American companies, pharmaceutical companies, and also chemical companies. Can you make anything on this list now? Can you make anything in the future if there's a crisis? What is your lead time for making this? How much will it cost? So then the government knows, what do I have a solution for now? What do I have a solution for in terms of crisis? What is the lead time that I have to build a stockpile until I get there? And then how much will it cost?
Well, that's reassuring. Thank you for your answer. Madam Chairman, that's it for me. Thank you.
Okay. Senator Daschle?
Well, this has been an extraordinarily interesting panel. Thank you for your presentations. You've offered a plethora of recommendations that I hope we can follow up on, but I appreciate the depth of knowledge and relevance that you each have reflected in your answers to our questions. I guess I have a very basic question. Given the myriad of challenges we face in supply chain policy today, I'm still confused as to how we ought to look at priorities. And I would be very interested if each of you could give me what you believe to be the first and second highest priority as we look at the supply chain challenges we face in the coming years. Dr. Hart, let's start with you.
Tough question. I mean, I would say first, don't think we can do it alone. So in parallel with doing our mapping at home, we should have a very good map of what our allies and partners are producing as well, because that goes right into the priorities of what has to be onshore and what doesn't. And then the second, I would say, funding alternatives to companies like WuXi AppTec that do the biological manufacturing. That's one Chinese company that many of our drug producers are relying on. And I've talked to small biotech companies that make, the kind of company that makes one drug. that many Americans depend on to stay alive, to stay healthy, to be able to go to work and go about their lives. One company has told me that if they lost access to WuXi AppTech, it would take them 8 years to come back online because we aren't investing in alternatives. So that would be one of my priority asks is put the funding in to develop a U.S. alternative so that that is not an innovation bottleneck. And the other would be work with allies and partners on this stuff because we all share the same challenge.
Thank you. Very helpful. Dr. Yu?
So my two pleas, first one, I think I've said it many, many times, is that we absolutely critically need to expand the scope of what we characterize as biological threats beyond just the WMD, beyond the bioweapon. It is absolutely a biotechnology space race. Secondly, and it's you'll understand why this is important. I firmly believe that we are in this biotech space race. I think China's moves have constituted the Sputnik launch wake-up call moment. It's not as spectacular as it was back when the Soviet Union launched theirs. But what did Congress do in the immediate response to that when they realized, wow, we're behind? One of the first things they did was pass the National Defense Education Act. And that dropped billions into our university systems to develop the next generation engineers, physicists. We need to invest in our students and our talent pool because right now, what are we doing? We're cutting back on research funding. We're driving away foreign talent. That critical aspect of a space race and a biotech space race, we are not doing security adequately, and we're definitely not making the investments that we need to make to ensure that the U.S. maintains its leadership in biotech innovation.
Could I just follow up on your first point that we need to broaden the definition of biological threat? I would be interested in just two aspects of that assertion. One is, how would you define it? Could you be a little bit more specific as to what that broadened definition looks like? And secondly, to the extent there is resistance, where would the resistance come from?
Right. So let me go backwards. I think the resistance right now is our current frameworks that addresses biological threats are still Cold War era looking at the bioweapon. I understand why that's important, but it needs to be broader than that. And I'm looking at Secretary Wednesday because if you're Department of Homeland Security, this should be a pain point for you because in order to understand the framing, it means that those very processes that are implemented per Congress is looking at the biothreat risk assessment. It means that understanding biotechnology has tendrils, the octopus analogy, in each of our critical infrastructure sectors. It's not just health, it's agriculture, it's manufacturing, it's sustainable renewables, energy production. And if you acknowledge that, then that should be incorporated into how we assess cybersecurity, how we assess looking at infrastructure protection. That's not being done. And if we do that, which is commensurate with our biotechnology, we will be much better off in understanding what the risks really are. And that will help the decision makers, whether it's at the White House or in Congress, be able to make the right moves. But we're not doing either of those right now, unfortunately.
Thank you. Very helpful. Ms. Kaktar?
Yeah, well, I appreciate the question because it's also thinking about, like, what do I focus on next? So as a supply chain expert, other than, small molecule pharmaceuticals and critical minerals, I'm really worried about having adequate semiconductor wafer manufacturing capability here and super abrasives, the industrial diamonds that go into literally all manufacturing that China controls the entire global supply chain. But I want to share a story from when I was in the government. I was trying to sort of bring the supply chain practice to the Commerce Department, and we were doing that. And when the pandemic hit, the National Security Council said, "Okay, Nizak, you're in charge of supply chain. Let's onshore whatever we can for national security. Go figure out how." So I went to my team and I said, "Let's identify everything that's critical to national security." And my entire team said, "We don't know how to do it." This is the government at the International Trade Administration. And I said, well, the Harmonized Tariff System Code of the United States has made this really easy for us. Let's have all of our sector experts look at their chapter or subchapter, figure out the 10-digit code that's really, really important to making satellites, making cars, whatever. Let's create a master list. So we did that. Then we said, well, how much do we produce versus imports? Well, the US government, you can't run a company without knowing your inventory, yet we run a country without knowing what we produce here, right? So we've got the NAICS codes, the HTS codes not harmonized. So instead of figuring out what we produce domestically based on the HES codes, we just looked at import share. China versus the rest of the world, Indo-Pacific over the rest of the world, India, for example, over the rest of the world, and we got a sense of where our vulnerabilities were. And then the solution set was, let's start. I know tariffs invoke a lot of antibodies, and I'm not talking about tariffs as a policy tool, I'm talking about tariffs as an economic tool. If the growth of a domestic industry, if an industry can't get into a market or can't grow because of price manipulations, then tariffs make sense to eliminate the distortions and create a level playing field. And I think every economist, whether they like tariffs or not, really do understand that there's a benefit for tariffs to level the playing field. And so the recommendation was for the 700 items we produced, 700 that are critical national security, including healthcare, and we looked at the China import vulnerability, Indo-Pacific, et cetera, we had recommended levels of tariffs that would eliminate the distortion in onshore capabilities. And when we don't onshore, we work with our friends and allies. But there's no excuse that the US government can't produce a list, doesn't have a list, because we did that in 1 week. 1 week.
Thank you.
Okay, Fred?
Just two things. One, I would just follow up with Anna's question on the 232 investigation. So the administration should complete it this month. We'll have a little time to review it. Who then is going to be responsible for negotiating what they might do with China? Is it the International Trade Commission? I mean, who in the administration is going to do this?
Sure. So our experience with 232 thus far has been really limited. But when the president had, only once before the president had said, I'm going to put action on sort of the ice until we negotiate our way out of this. And that was in the first Trump administration. That's when Ambassador Lighthizer negotiated USMCA, right? And then we sort of stalled on the auto tariffs. One would assume that that would be Ambassador Greer. But right now, a lot of the negotiations are happening by Secretary Lutnick and Secretary Bessent, in addition to Ambassador Greer. So I think the president is kind of picking out which cabinet member he wants to negotiate. So it could be any of them. But then the key question is, what are we negotiating? The large molecule biologics, I mean, the U.S. is robust. We work closely with South Korea, who's amazing in this, Europe, who are amazing. I don't think there's anything to negotiate there. We're fine. On the small, what are we going to do? Negotiate with China and India? China is just, negotiating with China is like talking to a wall. But then India's a little bit divided on these things, right? So what's the likelihood we're going to get any real concessions from India, at least in the long term?
Yeah. And I just want to say thank you very much for your presentations. It's, sitting up here, it's, to me anyway, it's a pretty bleak picture. To say the least. It's one of the things that I did working with Anna and Susan Brooks when we did 21st Century Cures, which it's 9 years almost to the day that President Biden signed it into law. And one of the driving forces that we did, this was a huge bipartisan initiative, as you know, 392 to 26 in the House. I still remember the 26. But we saw that the supply chain and the development of drugs had really began to move overseas. The venture capitalists, the approval process. And we worked with all of the stakeholders to bring that home. And one of the things that we did that was so important, working with everyone, particularly on our committee, was that we invested $45 billion in additional funds for the NIH and for the FDA. And I said to say we don't have our former FDA commissioner here because she was very important too in the process to get it done. So here, and we paid for it. I mean, Speaker Ryan, Speaker Boehner, we did that. All expires now, but tragically what we've seen, particularly this last year, is the reduction of funds for the NIH and the FDA in a rather dramatic fashion. I was there at the Lincoln Memorial in March, the Rally for Science, when we saw these cuts coming. And somehow Congress has got to get their act back together again, particularly as we look at, when this act technically does expire because of the pay-fors expire this next year. But they got to get their act together and look at a 21st Century Cures Part 2 to look at the future and to see these alarming changes that you are bringing to our attention, but certainly needs to happen about 14 blocks east of here as well. So I just want to thank you for your presentations. I know that Ann and I will share it with our former colleagues that are on the committee as they look to try and do something as this expires. But thank you so much for your involvement, and I yield back.
Thanks, Fred. Jim?
Thank you. I want to address a question to you, Mr. Yu. You referenced the mRNA vaccine cut of $500 million in research that was to go, I think, mostly to academic institutions that Secretary Kennedy killed, and which, if I may issue an editorial comment, was an insane act of anti-scientific craziness. What I'd like to ask you is, and the response from Republican members of Congress, at least, has been almost inaudible. I think Senator Cassidy said it was unfortunate. I think it was more than unfortunate. So unfortunate. So could you talk a little bit about what you think the impact of that loss of funds is, number one, because I think you said the Chinese are already able to develop mRNA vaccines 138% or something like that, more effective. What are we losing? What are the opportunities that we're losing in terms of public health benefits? And what do you think the prospects are of undoing this? I saw that the House Appropriations Committee put $1.1 billion into BARDA, but BARDA's portfolio was pretty broad, so I don't think that's going to. And they made mention of that some of this money could be used for mRNA vaccine research. So what do you think what do you think the losses that we're going to face are, and what do you think the prospects of undoing this? Will it require a turnover in the Congress and wait until the next administration, do you think?
Right. So I think what happened with the mRNA vaccine is a symptom of a much broader strategic issue, and it kind of goes back to how we frame the biological threat. So, and I think it's an opportunity space. Because when we have events like this, which again, it's a privilege to be here. We need more events like this, but we do ourselves a disservice that when we come in and then the framing to Congress in particular is that how do we prevent the zombie apocalypse, right? I'm a big fan of the Commission's comic book, but it's got to be more than just that. And I think it goes back to that equation that I provided before, in that we're talking about not bioterrorism, but bioeconomy security. So if you especially for our Republican partners, understand tying in bioeconomic security equals economic security equals national security, it's a much different proposition. And especially for your constituency, you're looking at whether you're a large pharma, looking at your large, ranging from your R1 universities, even all the way down to the HBCUs, which are also centers of innovation, suddenly becomes really quickly how critical it is for our innovation base. And not just for the sake of science, but for the sake of economic growth and economic innovation. We're not making that case. So I think if you can just boil down into talking points of what this panel in particular has highlighted, China's absolute strategic prioritization of biotechnology, where we're falling down on both on the security, but especially on the investment side, where we need to strike that balance. And then the opportunity space is not just for expanding what constitutes a risk, but if we do our risk assessment properly, what we also do is identifying what the green spaces are. What are the greenfield opportunities? Because there are going to be some areas where we're going to have to understand we're not going to get that high ground back from China. Fine, so be it. But it also means, where do we do the next leap forward first? Where do we continue out innovating? And unfortunately, we're not doing any of those things right. However, having said that, if we have our collective will, and I'm happy to report that before my retirement, when I did have the opportunity to provide this perspective to different committees on the Hill, there was broad bipartisan support. Because there's no room for partisanship in this space. And the fact is that I have young children going to college, and if we don't do this right, then by the time they graduate, what prospects are we offering to them? So I think it's incumbent upon us to make sure that we do this right.
think I have half a minute left. So on the API issue, there's been mention of using tariffs to try to equalize the level of the playing field in terms of competitive pricing. I think you also mentioned loans and so forth. It would seem to me we probably need to have two things happen. I'd like you to comment, any of you to comment on it. One is real subsidies to the manufacturing industry here to say, if you make this, we'll give you make the investment in it because it's critical for national security. And secondly, do you think it would be required to compel the pharmaceutical companies to say, and you will buy it from U.S. companies, not from Chinese companies?
So
You've got to get the end user in there because you got to sell it to somebody, right? And you've got to be able to sell it to somebody with the U.S. price, not just the China price. So I think the missing piece here as well, can we have Medicare, Medicaid, other state-funded programs in the United States prioritize reliability? Right now, it's just price. And if it stays just price, then it comes from China. You can tell U.S. companies, you have to make it here, you have to source your goods from Europe or wherever, it is going to be more expensive. So who's going to buy it at the end of the day? You just have to rack and stack throughout that system.
Insurance reimbursements can go a long way in terms of we'll reimburse if it's American made or ally made, but not if it's China made. We have sort of different legal tools to do that.
You can if you subsidize it enough, it would seem that the price could be, you wouldn't have to increase the price. You subsidize the manufacturers, and therefore they can sell it to the pharmaceutical companies at a lower price. Is that not right?
Here's my experience. So when we try to get like a domestic industry up and running, right? First, we've got to have a level playing field, and then we have two choices. We wait for market forces to kind of find its way to invest in that sector, or we use government funding, subsidies, et cetera, to accelerate. And I think government funding is a really, really important accelerant. But then what happens? We've built this company, right? And this is sort of what the government is grappling with in critical minerals. You built an industry, you've built a company. If you don't keep the playing field level, they'll just get decimated by China, and all that money will go down the toilet. So we build a company, we use subsidies to accelerate, and then we have to find, as Melanie said, we have to find end-use market. And I think we can do that very effectively legislatively, either through insurance or just plain old what was done in the first Trump administration, ICTS, that's still a valid law. President Biden endorsed it too, using IEPA to prohibit transactions with foreign adversaries, right? The government has to be serious and help the private sector make the right choices. The private sector, as we know, doesn't always make the right choices, but that's why government's important.
Thank you.
And if I may, real quickly too, it also requires understanding the Chinese got it, and they had enormous regulatory reform. So if you think about it from our standpoint too, if you're a U.S. company and you're a biotech company, you have a unique startup, you're going to do a lot of looking to see what glide path that is already pre-approved by FDA, USDA, EPA, because coming from a bio perspective, you're not going to take that risk for branching into something new. So until the regulatory space can accommodate breakthrough, really true innovation, companies are going to be incredibly risk averse. So you have to give them the environment, the ecosystem to be able to try new things and be able to have that fighting chance to bring it to commercialization. China gets it, and so they are allowed some of that permissive while at the same time maintaining quality control because they learned their lesson.
Thank you.
So we're past time, but Rachel or Scooter, do either of you have a quick question?
Just a quick question, I think, following up on the fact that the panel has just demonstrated their knowledge of what happens in different parts of the government. One of the things that the Commission has tried to do is a report card on what agencies have done, what they ought to be doing. Can you, given your experience, would you say where in the government currently would be the appropriate expertise and authority pulling together the recommendations that you've already made today to put them into a package that would affect the outcome that you've been describing as what we need to be doing?
Sure, I'm happy to start that one. I'd like to see the U.S. Congress do an innovation action plan for pharmaceuticals and biotech, because this isn't partisan. This isn't one administration China does these big 5-year plans, 100-year plans, 20-year plans. If we want to compete, we have to do the same. And I have the same experience these guys have. When I'm meeting with Republicans or Democrats on the Hill, there's interest across the aisle, across both houses of Congress to do something. But I think we need to have the American people lean in a little bit more and demand something and signal that we want to see our taxpayer dollars focused on fixing this problem. We need a congressional action plan, an innovation plan for pharma and biotech.
Thank you.
So 2 things right off the bat, and I already mentioned one of them, is that is very pleased to see that Congress established the Biotech Caucus recently. But then the genesis for that, and I'm not sure if the commission have already engaged with them, but absolutely engaged with the National Security Commission on Emerging Biotechnology. And they came up with multiple legislative recommendations. I can't think of a better one-stop shop to look at these issues and actually come up with some policy recommendations.
I guess I'll add that having dealt with so many agencies in the federal government, the federal government, the different agencies have too many different interests and conflicting interests to provide a good set of recommendations. It ideally should come from the White House, the National Security Council, National Economic Council, but we never have experts in the White House who literally know all the tools in the tool chest to know how to deploy them, which is why we find ourselves in this situation over and over again, which is why the commission is so important, because you can speak to different experts and hear about the different problem sets and then determine based on your expertise which ones make sense and put a comprehensive list together, but then also hold the administration's feet to the fire, whether it's ours, whether it's D's. We're all Americans. People's feet need to be held to the fire. If they're going to go in the government, then they're going to serve, and they've got to serve the American people and not personal interests.
I'm sorry. Actually, could I just follow on, Melanie? Just interesting. The innovation plan. You see that as a product of Congress, of legislation, as opposed to something from the executive branch?
Yes, because it's not free.
Yeah.
Right.
So they
no
have to
one
appropriate-
expects DoD to compete with $0. We get that. We get what that competition looks like. If you want to be in the game, you need to have the latest weapon systems. You need to have updated war plans. Congress understood that we needed the same thing for the semiconductor sector. There's a little bit of maybe, sort of, kind of maybe in the rare earths and critical minerals sector, glimmers coming through. Biotech and pharma will be the fight of the century. This is the next big U.S.-China competition, and we can either run backwards or run forwards, and that's a Congress decision.
I do a lot of work really quickly in critical minerals, and what China has done is incredible for American innovation. I am personally so happy to see what's happening in innovation. It has unleashed American ingenuity. And not only are American companies innovating, they're finding partners domestically, they're finding partners globally to provide the whole vertical supply chain for the United States. So I very much believe you also leave it, of course, with a government plan, but you leave it to the private sector. America still has that desire for innovation.
Scooter.
In recent months, I haven't received enough depressing information, so I want to thank the panel for correcting that deficit. One quick question. Obviously, you've made it clear that there are huge economic costs to not solving this problem, as well as strategic costs. Would you share either now or in the weeks to come the best estimates of the net benefits and net costs of doing what you're suggesting?
I mean, as a China expert, I don't want to be put in the situation where Xi Jinping decides if Americans live or die, right?
I understand the strategic risks. What I'm questioning is if someone has actually costed out, these are expected losses of revenues, these are expected costs of subsidies and of these other things, to make it clear, which I think you all support, I'm intuiting you all support, is that in the long term, over 10 years, we will spend much less money than we will gather in by saving our industries from becoming second rate.
Yeah, I think the National Security Commission on Emerging Biotechnology's April report is the best that I've seen so far.
As I don't know if others are economists here, but as an economist, I'm happy to take that on. I've done similar estimates on the critical mineral space. And these are just going to be estimates, but there's enough data out there to provide at least a working guess. And like I said, I'm happy to take that on.
And I'm going to cite The Schmidt Futures Foundation did a great report on the bioeconomy, and don't hold me to these numbers, but I think they estimated something to the order of $40 trillion within the next couple of decades globally, and that's the piece of the pie that we're going to potentially miss out on.
But, I also want to really underscore that when we invest domestically, we're investing in GDP output, where, workers go get jobs. This notion that Americans don't want to work is absolutely not true. I represent workers in the poorest parts of the country. Americans want the dignity to work and have money to put food on the table for their children. And so I think that the economic benefits of manufacturing here in orders of magnitude are going to be significant in the long term. But all of that, I'm happy to try to figure out and present.
Can I just add something to this? I know that we feel overwhelmed by all of it because these are enormous challenges. But we've risen to challenges before in our great country, and we can do it again. It was almost 2 decades ago when there were some of us in Congress that thought that an innovation agenda should be developed for the country. And so we members went across the country. We started at Stanford University with the private sector, with academicians, private sector participation. We took the effort across the country. So it was, it was bipartisan. It was nonpartisan, really, and then hammered out a legislative agenda to meet the challenges that had been pointed out to us. So, and they were funded, as well. So, in our, I know it's cold and it's gray outside, and there's a lot of grayness in terms of, everything that's going on. But I believe we can do this, and I think the Commission is really poised to play a key role in this. And I again thank the panel. You've been highly instructive to us.
And may I add just one quote? It's only 25 years that China has started to sort of really hollow out our manufacturing base. It's only 25 years. That's not so long that we can't correct. So I really wanted to underscore your point. It is this problem that we can absolutely solve because it hasn't gotten so out of hand.
Well, Anna, thank you. That was great. Note of hope after Scooter the Downer over there is all depressed. Sort of like a good Springsteen song. Life is rough, but at the end there's always a reason for faith and hope. So thank you for that. But you guys have been great. All our panels are excellent, but you guys really knocked it out of the park. So thank you so much. Appreciate it very much. All right, lunch break until?
1 o'clock. Okay. About 1:05, 1:10.
Okay. There you go.
I'll give everybody a little bit of time. If you think there's no place that has a free lunch, you have a free lunch outside.
Everybody listen. You're all here because we all love science fiction, and I assume some of you read a book called World War Z. The reason we're here, the reason I'm here with these grown-ups is we're going to talk about the real World War Z. We're going to talk about real plagues and real bioterror, and also how easily it is to stop, even easier than zombies. So I'm going to turn the floor over to Asha George, who former Army intel officer and knows a thing or two about bioterror.
Thank you. Thanks. Thank you, Max. Hi, I am Asha George. I am a former intel officer in the Army. I also happen to have a couple of degrees in public health and have been looking at biodefense for quite some time, for many decades now. I'm the executive director for the Blue Ribbon Study Panel on Biodefense. And aside from that,
Everybody, listen. You're all here because we all love science fiction, and I assume some of you read a book called World War Z. The reason we're here, the reason I'm here with these grown-ups is we're going to talk about the real World War Z. We're going to talk about real plagues and real bioterror, and also how easily it is to stop, even easier than zombies. So I'm going to turn the floor over to Asha George, who former Army intel officer and knows a thing or two about bioterror.
Thank you. Thanks. Thank you, Max. Hi, I am Asha George. I am a former intel officer in the Army. I also happen to have a couple of degrees in public health and have been looking at biodefense for quite some time, for many decades now. I'm the executive director for the Blue Ribbon Study Panel on Biodefense. And aside from that, I would like to introduce Ken Weinstein to Max's right. Ken Weinstein has been involved in public service for quite some time. You can check out his bio online, but I think there are a couple of interesting things that you might want to know about him. One is that he was the chief of staff for then FBI Director Robert Mueller, who put out a little report himself a little while ago. And also he's the former Homeland Security advisor under the second George Bush. Then of course you know Max. I feel a little silly introducing Max. For those of you who don't know, he wrote a little missive called World War Z. And I'll just take 1 second to talk about that. From our perspective, that is an outstanding book. And it's not just because it's interesting, and it's not just because of the zombies. It is one of the best books on public health investigations, how you would do it, what you need to think about, how you need to think outside the box, and how crazy and painful and urgent something like that can be. We very much appreciate that. In addition, Max has been responsible for some graphic novels, as you know, and today we're going to be talking about the one he's agreed to do for us. So let me turn it over to you, Max.
Okay. So you guys, obviously, you know World War Z, and what you might not know is the novel World War Z was on the reading list for the U.S. Naval War College. And the president of the Naval War College, Admiral Weisskopf, called me, this was about 10 years ago, and said, we'd like you to come speak. And so I said, are you sure you have the right guy? And you can see it on YouTube when I'm speaking, and I'm sort of flop sweating, and I'm nervous, and I keep thinking, like, isn't there a... Mike, isn't there like a lieutenant... Can you all hear me now? All right, let's recap. World War Z, Naval War College, oh my God, are you sure you have the right guy? But I must have said something, because then I started getting invited to speak at panels, and not here, at strategic studies groups. And I started running in military circles. Then I was invited to join a military think tank called the Modern War Institute at West Point. And it's an impressive stand-up of people. It's active duty Army officers, intel analysts, prestigious academics, and me. What we do is we study conflict, all of its perspectives, because conflict doesn't just mean people shooting each other. As we all know now, we are in an age of what they call the gray zone, which we all know: cyber war, intel, information warfare, economic warfare, and germ warfare. There's many ways that people can hurt other people. And as part of my job for the Modern War Institute, I wrote an article about Zika. Remember when Congress was dithering about Zika and they were like, oh, well, maybe we should give money to fight it or maybe not. And I'm like, are you crazy? What if Zika had been cooked up in a lab? You guys are giving trillions of dollars to the military to blow stuff up, and you won't spend a penny to stop a germ coming in that's actually hurting us? And I thought nobody listened. And then I was tapped by this Blue Ribbon Biodefense panel. And these are people who are already working on keeping us safe. And they asked me to come to one of their hearings right down the street. And it was an emotional roller coaster. It was up, it was down. Here's the bad news. Here's what I learned. The bad news is we are in a new age where it's very easy to get your hands on a germ. I don't know if you guys read the news lately about this homegrown terrorist, the ex-Coast Guard guy, or I think he might have been active. He was arrested right around here with a bunch of guns and a bunch of bombs, and he was ready to kill people, and he had a hit list. But what he also had was an internet search on the dark web where he had asked, how do I get my hands on a germ? Because I want to kill the most amount of people I can. Now, 20 years ago, you would have to smuggle things like anthrax out of a lab and then mail it around the country. I have a little bit of experience about this, because when I wrote for Saturday Night Live, our workplace was hit with an anthrax attack. And I came into work and the whole place was shut down because there was anthrax. But that was 20 years ago. Now, anybody in a few years will be able to download the information for genetic manipulation and the kind of equipment that would have cost millions of dollars and you'd have to steal from a Soviet lab. You can get off the internet. You can get off eBay. So we're approaching the age of the homegrown bioterrorist. That's the bad news. The good news is we just got to keep doing what we're doing to stay safe. Because germ warfare is the one place where you don't have to decide between peace and war. It's just public health. It's just investing money in our doctors. It's believing in science. It is vaccinating your children. It is doing all the things we used to do to keep natural viruses at bay. The problem is we've done such a good job of it. We're 3 generations away from those horrible days. So people are starting to question, and we're starting to backslide into ignorance. In order to get here, I had to walk through LAX, which was quarantined for measles, which supposedly had been wiped out. So we can do this. And that's what I learned at this hearing between these people. Oh, wow, we can do this. But the one piece of the puzzle they were missing, because they had a ton of experts, doctors, intel experts, logisticians, what they didn't have was public outreach. Because they might be the experts, but we're the boss. Because we're the voters, and we're the taxpayers. We make the decisions. And so if we don't educate ourselves, we're not going to vote for the right people who have the right programs, who keep us safe. But how do we do that? Because you guys shouldn't listen to this part. The problem with expertise sometimes are experts, right? And sometimes and we go, or sometimes they go too deep and we go, oh God, and we get scared and we go away. So how do we educate ourselves? What's a great tool for educating people like us? This. Comic books are not just entertainment. They're one of the greatest teaching tools ever. The US Army used to do it to train troops. The UN does it for public health. Recently, in an African country, they just put out a whole graphic novel on how to tell science apart from folklore. And by the way, the alt-right is using it to try to train people up. There's a lot of alt-right comics happening right now. So the bad guys get it. And we need to get it too. And so we've all gotten together and we put together germ warfare. And it's totally free. And you can get it at the doors when you leave. And it's just a history of how people have used germs through history to kill each other. Going way back to the ancient Greeks, when people put arrows in dung and blood and every arrow got an infection, to when they used to catapult dead plague bodies over city walls, to the Japanese experiments in World War II, which they dropped flea bombs on China, to the Cold War, where we used to have massive stockpiles. You know, in the Cold War, we always talked about nuclear stockpiles. We used to have germs too. And we might have gotten rid of our stockpiles, but other people haven't. So it's a reminder of where we've come from. So when you guys are watching TV and you see someone on CNN saying we need to invest in good public health, you go, oh yeah, because what keeps us healthy also keeps us safe. And that's why we're doing this project. And so I'm gonna what we're gonna do now is Mr. Weinstein is gonna talk to you for a little bit about what it means to keep us safe. And then I think the best thing to do is open the floor up to your questions. And we will try to answer them the best way we can and not put you to sleep and not freak you out. Go for it, Ken.
Okay, good to see everybody. As Max said, there are these experts out there who put you to sleep. Warning, that's me. Just everybody be duly warned. Sorry, I'm actually not that much of an expert. You got the real expert here you're going to hear from, but I guess I know a little bit about how this city works, and that's why I'm here. But you might ask, why is sort of a, middle-aged charitably, but middle-aged Homeland Security lawyer speaking at AwesomeCom, and that would be a darn good question. And then the next question might be, why is a boring Homeland Security lawyer joined at the hip with a guy who's an expert on zombies and graphic novels? And that'd be an even better question. But the reason is because we both share the same concern. And you heard it from Max just now, and that is the concern with the threat that this country's facing. And that we faced for years, but now I think we're at a sort of a critical point, and it's something that we really need to get the message out about. And I'm thrilled that he's here. He's been a great partner. And he's been a great partner to us, but also to this whole panel. And Asha told you about this. Very DC thing, right? If there's a problem, what do? You set up a committee, set up a panel, and then talk the issue to death. Well, we've done a little bit of that. But we've also, made some results. This thing got stood up in 2014, I believe. And we got some people who are really impressive. We have Joe Lieberman, Tom Ridge, Donna Shalala was on the committee until she became a congresswoman just the other day. And Jim Greenwood, Lisa Monaco, former Homeland Security Advisor, and then also Tom Daschle. I saved Tom till the end because, as you know, he was U.S. Senator, Majority Leader, but I think most importantly for here, he was the victim of the anthrax attacks. He actually got a letter sent directly to him, so like Max, he was directly affected by one of the main bioterrorism attacks that this country has had. And so he brings a really important perspective, a very personal perspective to our work, and I find it very valuable. Anyway, we've been working now for about 5 years, and we've done all the DC things, right? The sort of the methods we've used. We've had congressional testimony. We've had meetings with Congress people trying to push them to legislate to enhance our biodefense, to appropriate for biodefense measures, this kind of thing. We met with the White House, pushed hard with the White House, both the Obama administration and the Trump administration. We've held just general public hearings. That's how we got to know Max, because he came and gave a riveting statement to us about the problem and how he saw it from his in-depth research for his book. Anyway, those are the things that we've done, but still, and we made some progress. I mean, we've got, there's a national strategy that's now been put out. Once again, that sounds very wonky inside the beltway, but it's important. It shows that the executive branch, the administration has said, this is important, we need a national strategy, we've got to get all the authorities to coalesce, all the different agencies and departments to coalesce around this objective and push forward. So we got that. That was one of our recommendations. We've gotten legislation from the Hill about the national strategy and about the budget. So we're making progress. But where we really need help is getting the message out more generally, because, as Max said, it's when the people, those of you who are at risk, those of us who are at risk, are actually making the point to their legislators, in the press, generally, at cocktail parties, whatever, that, hey, this is important. And the problem, and that's where this comes in, and that's where Max comes in, and just wait till you see this book. It's fabulous. I read through it again for the second time this morning, and, besides some eye-opening pictures of chopped off limbs and this kind of stuff, which is, a little tough when you're eating your Wheaties in the morning, but really it makes the point. It really drives home how this has been a constant issue throughout history, all the way, as he said, to the classical era, and how it continues to be an issue, it being the threat of bioterrorism, the threat of pandemics, the whole 9 yards. And so the point here is, let's get this message out and get it out loud and clear. Hence, we got today. So what I'd like to do is just, ask you all to listen carefully, think about what Max has said, take a look at his book. I think it'll make you realize how serious it is. And if there's one thing that you get out of this book, it's the following. And this is what actually has motivated me since when Asha and a couple of her friends first approached me about doing this, is that, when we think about the threats that we're facing, we all think about the nuclear threat, big problem. As Max points out in his book, hard to actually build a nuclear bomb. Hard for a terrorist to get the uranium, get the know-how to make a nuclear bomb. We worry a lot about, the just conventional weapons, the terrorists will get. Yes, that's a danger, but they might kill a certain number of people, but there's sort of a maximum number of people an individual with a typical conventional weapon can kill. But, the bio weapons are available anywhere. People can work them up in their basement, and they can kill people by the tens of thousands, if not more. And that's why I think this is a threat that really needs everybody's attention. It doesn't get enough attention because, when you're not hit with something, politics moves on and looks at the other things that are more recent threats. It's only when the people step forward and say, government, we need you to do something about this. That's when we get action. That's when we get defenses up, and that's when we feel safe. So this is an important part of that process. Really appreciate you being here, listening to us, and look forward to your questions.
Yeah, what do you guys want to know? Yes. Mike? Germ Warfare, A Graphic History just went live today. It is free. It is downloadable. You go to germwarfare.org and you can download a copy for free. Yes, miss.
Good morning. It seems to me that this issue interlocks with the broader big picture issue of what keeps an animal healthy and happy. The social, getting enough sleep, getting proper nutrition, proper health care. I used to be a zoo docent. I saw when you give an animal the correct basic care, it lives long. I see a lot of Americans who don't get correct basic care. They don't do so well, and they are more vulnerable to infection in a way that a well-cared for animal is not. So how does your initiative interlock with that broader complex policy of keeping us all in that good space?
Thanks. Thank you for that question. It's a very valid question. You're talking about the environment in which a virus attacks anything and anybody. And good public health practice, good healthcare practice allows for exactly what you're saying. It's a broad issue. We have to look and see what's happening right now in the world. We have some of the worst outbreaks in places where there is insufficient money because of poverty, insufficient public health infrastructure, or insufficient health care, and so forth. And so what do we see? We see more people getting sick there. Any policy that we take in terms of addressing biological warfare, bioterrorism, and naturally occurring diseases has to take into account good nutrition, public health infrastructure, access to health care, vaccines, as Max brought up, access to antibiotics, fresh water, all of that. If we don't do that, we are creating additional vulnerabilities that we don't actually need to have be there, at all.
Hello. So I want to first say thank you to everyone on the panel for being here today. And I also want to say, Max Brooks, so the day after I read your book, World War Z, I looked into Masters of Public Health programs in epidemiology. So I was inspired to go into that field. I absolutely love it. I don't exactly do epi stuff, data analyst, but still, thank you. Anyway, so I had a question kind of like in regards to, so within the United States, we have these wide open fields of like agriculture where we're growing plants and we're raising cattle. And so I previously had taken a plant pathology class, and they did say it is a concern, like bioterrorism, because we have these wide open fields. And so I was wondering, like, how much of a concern is that for this panel? And if so, is there a way like that we can like prepare for kind of like the worst case scenario for that? Just curious.
Let me just give you a quick short answer, and then we'll dig into the experts about this. Whenever you hear an attack on regulations, this is we're over-regulated, there's regulation. There's a reason we have regulation. There's a reason we have the Food and Drug Administration. There's a reason we have a Department of Agriculture. All of you would be a lot richer if we didn't have to pay for those things, but we'd all be dead. The reason we have that is so we can check and we can monitor. One of the things the panel is doing is trying to open communications between all these departments. So if a virus does show up, it can go, say, to CDC and then to the Army USAMRIID, and they can get, oh, wait a minute, there's a genetic footprint on this that doesn't match a known strain. So that's why we have regulations.
Yes, agro-terrorism, agricultural warfare is a huge, huge concern to us. There are things that are termed blast. There's wheat blast and soy blast, and the reason they use that term, I mean, other than the scientific reason, is because the introduction of something like that will just blast all the way through our crops. They could decimate our economy. The agriculture is such a huge part of our economy, and once started, we can't necessarily just stop it. Conveniently, when human beings get sick, yes, we can pass certain diseases on, but there's an incubation period. There's some stuff going on there, except for in World War Z. But with agricultural threats, it starts one place and it flies through. So it's a huge concern for us as well.
Is anybody here of Irish descent? You're right. Most of you are here because of that, because there was a blight. And that's another issue. So it's not science fiction. I mean, we literally have seen these disasters throughout history when a blight has come through and wiped out our food source.
Thank you for coming, you three. I appreciate your information. Just wanted to ask, do all viruses have the capability of being weaponizable? And if so, is there a virus that is a little bit harder in your experience to mitigate against, such as Ebola? I know that was a big scare not too long ago, and then it went dark, like nothing came from it afterwards. But was curious what would be the worst virus that could be that our nation could face that would be trouble to contain.
So yes, technically all viruses, all bacteria for that matter, could be weaponized. But you can see certain diseases don't affect us as much as other diseases. The worst case scenario now is a genetically engineered organism. But I say now, and would also call your attention to the fact that the Soviets, when they were, big into their biological weapons program back in the 70s, they experimented with inserting Ebola into influenza because we get sick with influenza much easier than we get sick with or infected with Ebola. Now, they didn't go on to do much more with that, so we hear, but that I think is the biggest concern. At the same time, we're talking a lot about intentional stuff and that, this is germ warfare. Pandemic influenza can be hugely, horribly devastating and terrible. Mother Nature modifies its own vaccines, its own viruses, and if we got a mutation that was truly, truly beyond, it would fly through the world. It would kill millions. So both.
So you're saying that it would be sort of like a surprise inside a package, if you will. If someone wanted to put another virus or genetically modify it and put it within influenza, it could be.
It would be
more of an issue.
It would be, and it depends on how the disease presents. If everybody's walking in, I mean, as it is, you guys know how many diseases are described by with symptoms that are flu-like symptoms, But if you're going into a hospital or to a laboratory and they're testing, in that kind of scenario, they may test and find influenza before they find the Ebola stuck inside the influenza.
Yeah, and that's a really good point because, younger people don't understand this, but anybody my age understands that we lived through the great modern plague of AIDS. And we know that for 10 years, nobody knew that it was AIDS. Everybody was dying of pneumonia. I mean, I think to this day, Liberace officially died of pneumonia. And this is where science crosses with the social, and this is where you guys come in. is that something like Ebola is so scary and it's so quick that it provokes a social reaction. Oh my God, Ebola, quick, we sent the army to West Africa. That's how much we cared. So imagine you're in West Africa dying of AIDS as an army convoy races by you to go take care of the Ebola. You know, that's what's happening over there. People dying of malaria, and they're like, quick, I'm dying. They're like, do you have Ebola? No, I have malaria. Wait. And so we need to understand there's a social element to every plague, because one of the great, we didn't wipe out AIDS in this country, but we won the war on AIDS, not with science, but with social justice. We all came, it was with education. We came together and we realized this is what we have to do, not to allow it to spread. There still isn't a cure for AIDS. There's no vaccine, but we're keeping it at bay because of education. Everybody listen. You're all here because we all love science fiction, and I assume some of you read a book called World War Z. The reason we're here, the reason I'm here with these grown-ups is we're going to talk about the real World War Z. We're going to talk about real plagues and real bioterror, and also how easily it is to stop, even easier than zombies. So I'm going to turn the floor over to Asha George, who former Army intel officer and knows a thing or two about bioterror.
Thank you. Thanks. Thank you, Max. Robert Mueller, who put out a little report himself a little while ago. And also he's the former Homeland Security advisor under the second George Bush. Then of course you know Max. I feel a little silly introducing Max. For those of you who don't know, he wrote a little missive called World War Z. And I'll just take 1 second to talk about that. From our perspective, that is an outstanding book. And it's not just because it's interesting, and it's not just because of the zombies. It is one of the best books on public health investigations, how you would do it, what you need to think about, how you need to think outside the box, and how crazy and painful and urgent something like that can be. We very much appreciate that. In addition, Max has been responsible for some graphic novels, as you know, and today we're going to be talking about the one he's agreed to do for us. So let me turn it over to you, Max.
Okay. So you guys, obviously, you know World War Z, and what you might not know is the novel World War Z was on the reading list for the U.S. Naval War College. And the president of the Naval War College, Admiral Weisskopf, called me, this was about 10 years ago, and said, we'd like you to come speak. And so I said, are you sure you have the right guy? And you can see it on YouTube when I'm speaking, and I'm sort of flop sweating, and I'm nervous, and I keep thinking, like, isn't there a... Mike, isn't there like a lieutenant... Can you all hear me now? All right, let's recap. World War Z, Naval War College, oh my God, are you sure you have the right guy? But I must have said something, because then I started getting invited to speak at panels, and not here, at strategic studies groups. And I started running in military circles. Then I was invited to join a military think tank called the Modern War Institute at West Point. And it's an impressive stand-up of people. It's active duty Army officers, intel analysts, prestigious academics, and me. What we do is we study conflict, all of its perspectives, because conflict doesn't just mean people shooting each other. As we all know now, we are in an age of what they call the gray zone, which we all know: cyber war, intel, information warfare, economic warfare, and germ warfare. There's many ways that people can hurt other people. And as part of my job for the Modern War Institute, I wrote an article about Zika. Remember when Congress was dithering about Zika and they were like, oh, well, maybe we should give money to fight it or maybe not. And I'm like, are you crazy? What if Zika had been cooked up in a lab? You guys are giving trillions of dollars to the military to blow stuff up, and you won't spend a penny to stop a germ coming in that's actually hurting us? And I thought nobody listened. And then I was tapped by this blue ribbon biodefense panel. And these are people who are already working on keeping us safe. And they asked me to come to one of their hearings right down the street. And it was an emotional roller coaster. It was up, it was down. Here's the bad news. Here's what I learned. The bad news is we are in a new age where it's very easy to get your hands on a germ. I don't know if you guys read the news lately about this homegrown terrorist, the ex-Coast Guard guy, or I think he might have been active. He was arrested right around here with a bunch of guns and a bunch of bombs, and he was ready to kill people, and he had a hit list. But what he also had was an internet search on the dark web where he had asked, how do I get my hands on a germ? Because I want to kill the most amount of people I can. Now, 20 years ago, you would have to smuggle things like anthrax out of a lab and then mail it around the country. I have a little bit of experience about this, because when I wrote for Saturday Night Live, our workplace was hit with an anthrax attack. And I came into work and the whole place was shut down because there was anthrax. But that was 20 years ago. Now, anybody in a few years will be able to download the information for genetic manipulation and the kind of equipment that would have cost millions of dollars and you'd have to steal from a Soviet lab. You can get off the internet. You can get off eBay. So we're approaching the age of the homegrown bioterrorist. That's the bad news. The good news is we just got to keep doing what we're doing to stay safe. Because germ warfare is the one place where you don't have to decide between peace and war. It's just public health. It's just investing money in our doctors. It's believing in science. It is vaccinating your children. It is doing all the things we used to do to keep natural viruses at bay. The problem is we've done such a good job of it. We're 3 generations away from those horrible days. So people are starting to question, and we're starting to backslide into ignorance. In order to get here, I had to walk through LAX, which was quarantined for measles, which supposedly had been wiped out. So we can do this. And that's what I learned at this hearing between these people. Oh, wow, we can do this. But the one piece of the puzzle they were missing, because they had a ton of experts, doctors, intel experts, logisticians, what they didn't have was public outreach. Because they might be the experts, but we're the boss. Because we're the voters, and we're the taxpayers. We make the decisions. And so if we don't educate ourselves, we're not going to vote for the right people who have the right programs, who keep us safe. But how do we do that? Because you guys shouldn't listen to this part. The problem with expertise sometimes are experts, right? And sometimes and we go, or sometimes they go too deep and we go, oh God, and we get scared and we go away. So how do we educate ourselves? What's a great tool for educating people like us? This. Comic books are not just entertainment. They're one of the greatest teaching tools ever. The US Army used to do it to train troops. The UN does it for public health. Recently, in an African country, they just put out a whole graphic novel on how to tell science apart from folklore. And by the way, the alt-right is using it to try to train people up. There's a lot of alt-right comics happening right now. So the bad guys get it. And we need to get it too. And so we've all gotten together and we put together germ warfare. And it's totally free. and you can get it at the doors when you leave, and it's just a history of how people have used germs through history to kill each other. Going way back to the ancient Greeks, when people put arrows in dung and blood and every arrow got an infection, to when they used to catapult dead plague bodies over city walls, to the Japanese experiments in World War II, which they dropped flea bombs on China, to the Cold War, where we used to have massive stockpiles. You know, in the Cold War, we always talked about nuclear stockpiles. We used to have germs too. And we might have gotten rid of our stockpiles,
chair. Si, senor.
Yes.
You didn't go to the Cheney funeral, did you? That's what I heard. Yeah. From hours long. The cardiologist made the point that he was not used to giving eulogies because he's not used to other people die on his watch. But I said
Scooter asked me to let you know he's going for
Okay.
Thank you.
So we're going to have someone chair the meeting.
We'll find it. Don't
on the
worry. We'll get it.
26th.
Don't worry.
Okay. But we've got to get we've got to start on time. We can't mess around with this. We can't be casually talking over lunch.
Madam Secretary, I just want to check with you. We're just going to.
Okay, we're going to get started. I don't have a gavel. Should have brought it back. So our third panel is going to focus on healthcare workers and first responders who rely on PPE to protect themselves and, by extension, their patients and loved ones in a biological event. And the resilience of our healthcare and public health workers population depends on that very equipment. In the years leading up to 2020, U.S. healthcare supply chains operated on just-in-time principles with minimal extra inventory, and over 50% of masks and other PPE originated from China and other low-cost producers overseas. For example, Texas-based manufacturer Prestige Ameritech invested in a new production machine during the 2009 H1N1 pandemic, only to go out of business later. COVID-19 saw a repeat of this cycle on a larger scale, and the market is now once again flipping. The National Institute for Occupational Safety and Health, NIOSH, and the National Personal Protective Technology Laboratory is the entity responsible for the standardization process for respirators. Panelist Victoria Slaughter's organization, Blueprint Biosecurity, has proposed a strategy that seeks to address PPE market failures. Their PPE strategy also recommends a strategy shift in the national stockpile, moving away from reliance on disposable N95s and towards a 150-day supply of reusable elastometric respirators and powered air purifier respirators. So we are welcoming Victoria Slaughter, who is the PPE Director of Blueprint Biosecurity, Nicolette Lusant. You can tell I switched from French to Spanish a lot of years ago. PhD is the Chief Policy Officer for the Healthcare Distribution Alliance, and Marianne D'Alessandro is the Director of the National Personal Protective Technology Lab at NIOSH with the Center for Disease Control and Prevention. So welcome. Why don't we start with Victoria?
All right. Thank you so much for having me. And
If you could just move that mic a little closer, that'd be
closer?
great. Thank you.
How's this?
Good.
All right. Yeah, thank you so much for having me, and thank you so much to the Commission for holding this meeting, and also for your persistent work in this space. I'm Victoria Slaughter. I'm the PPE Program Director at Blueprint Biosecurity. Blueprint Biosecurity is a nonprofit working to prevent pandemics and strengthen society's response to biological threats. We develop strategic roadmaps to fund research to accelerate practical technological solutions focusing on suppressing airborne pathogen transmission. This includes PPE, as well as technologies that have the potential to inactivate airborne pathogens in occupied indoor spaces like germicidal UV light. The genesis of our PPE program was driven in part by what we all observed during the COVID-19 pandemic. We saw the PPE shortages faced by healthcare workers and other critical workers. This led us to create a roadmap for preventing future shortages, identifying the most impactful and cost-effective interventions and associated policy options. I want to share a few core findings from our research and our recommended strategies to address them. Our major finding is that readily available respiratory protection is paramount in saving lives during the next emergency. Airborne pathogens spread fast, and effective respirators can't be improvised. During the COVID-19 pandemic, a lack of commercially available respiratory protection led to ad hoc solutions like people sewing their own cloth masks. We now know that these provided extremely variable protection. NIOSH-approved respirators are the most important tool that can be available on day 0 of an outbreak. Respirators work against all respiratory pathogens and can be distributed immediately. They can hold the line while threat-specific countermeasures are being developed. However, the U.S.'s current domestic market and supply chains are not prepared to supply respirators to the vast majority of our critical workforce in an emergency. This includes healthcare workers and first responders, but also the millions of workers who will need to work in person to maintain food, water, power, and other critical functions in an emergency. The biggest challenge to supplying respirators in an emergency is a large expected spike in demand. Respirators have a consistent but relatively small market. However, as we saw during COVID, the demand could surge 10 to 100 times in a very short span of time. It's impossible to expect domestic respirator manufacturers and their related supply chains to maintain this range of excess without planning and support. Because of this, we must pursue multiple paths to ensure there's enough PPE to maintain continuity of critical services during an emergency: onshoring capacity, supporting a warm manufacturing base, and stockpiling. First, we must onshore or nearshore our respirator supply chains and invest in domestic respirator production capacity. This means more than just supporting domestic respirator manufacturers. It means supporting filter media manufacturers, injection molders, all other precursor material manufacturers. ASPR's IBMSC program is doing really innovative work on this now. However, onshore capacity alone will be insufficient to meet emergency level demand for PPE. The routine market for respirators is simply too small compared to pandemic level need. Second, we should invest in a warm manufacturing base for our ability to surge production in an emergency. The majority of manufacturers operate close to capacity for prudent financial reasons. Additional capacity requires additional equipment, but it also requires additional storage space for the extra equipment and people to operate it, which can be a challenge. Building out these strategies will take time. And third, which is something that we can begin doing right now, is stockpiling enough respirators to ensure a bridge in response while production capacity ramps up. Stockpiling is the only way to ensure that quality NIOSH. We recognize that any stockpiling approach must be smart and cost-effective. The Strategic National Stockpile already provides the infrastructure for the rapid deployment of PPE to critical workers when a pandemic hits. One immediate step the SNS should take now is to stockpile reusable respirators, specifically elastomeric half-mask respirators. These respirators offer at least as much protection as an N95, but they have a soft rubber-like seal and replaceable filters. This allows them to be cleaned and reused repeatedly. Reusable respirators take up less space, last longer, and cost less than disposable alternatives. To break this down a little bit further, reusable respirators require 95% less storage space than the equivalent number of disposables and have shelf lives exceeding 10 years. These advantages make centralized stockpiling of reusable respirators 75% less expensive than stockpiling disposables over a 20-year time period. This means a single reusable respirator could replace hundreds of disposable respirators. That means better protection for critical workers and better use of taxpayer money. Over the next year, my team will be working to address key gaps in our nation's preparedness efforts, particularly around respirator protection needs and how to surge production capacity in an emergency. But while we continue improving our ability to manufacture on demand, stockpiling matters now. We can't afford to be caught unprepared when the next emergency strikes. Thank you.
Thank you. Mary Ann.
Yes, thank you, co-chairs Shalala and Ridge, and distinguished commissioners, for the opportunity to be here today to share my perspectives on the Commission's objectives. Specifically, to have the chance to talk about something that affects every responder, every healthcare worker, and really every member of the public, and that is how we make sure that we have the protective equipment that we need during a biological emergency. NIOSH's National Personal Protective Technology Laboratory is the place where all U.S. occupational safety and health respiratory protection is tested and approved, located in the heart of Western Pennsylvania and co-located with Morgantown, West Virginia. And it was started 100 years ago when the Bureau of Mines was created, and it still remains today. We approve all respirators, from the simple N95 respirators that Victoria talked about during COVID-19 that was used, all the way up to the very complex self-contained breathing apparatus used by firefighters and other emergency responders. During recent biological events, and even during the recent wildfire seasons, the public has come to recognize NIOSH approved as the gold standard. When a manufacturer obtains a NIOSH approval, they can be confident that the product will be safe for its intended use. And that means we have a very important role in any national biodefense strategy. Today, I'll briefly touch on 3 areas where we can make a difference: modernizing PPE standards, expanding the role of reusable PPE, and smarter stockpiling. First, PPE standards simply haven't kept up with what responders and the public need. We're still missing updates to basic fit requirements, shelf life validation methods, and we don't yet have a national standard for public use respirators, something that would help protect children, people with disabilities, and workers outside of traditional workplaces. Additionally, clearer selection and use guidance and standards are essential, especially given the confusion over N95s, KN95s, and surgical masks, and when each type of product should be used. We need to build in counterfeit detection requirements as well, with consideration to how AI can support counterfeit detection. 2 other actions needed to strengthen domestic PPE supply from a standard standpoint are better or more specific definitions of domestic PPE. Current Made in America rules are very vague, likely resulting in widely variable interpretations and reporting by manufacturers, and inconsistent and counterproductive implementation of programs and contracts. Also, respirators approved to other countries' standards should not be allowed to be sold in the United States. This is driving confusion and creating opportunities for unscrupulous manufacturers. To bring this all together, numerous National Academy studies in recent years have expressed the importance of establishing a central federal coordinator to bring agencies with overlapping authorities in these areas and missions together for more effective coordination of the PPE ecosystem. The second area is one we don't talk about enough, and that's reusable PPE. We know how quickly disposable supplies can vanish when the whole world needs them at the same time. Reusable PPE, on the other hand, can be cleaned, disinfected, and used over and over again. That alone can take enormous pressure off of the supply chain. There are countries that issue durable respirators, gas masks, and others to millions of civilians because they know supply shortages can happen. The logic is the same here. If we want reusable PPE to play a bigger role, we need clear, consistent standards. We need to be able to look at how these products are cleaned, inspected, stored, and used, and clear guidance in those areas, including filter change-out schedules. We also need continued investment in durable and comfortable designs that can withstand repeated cleanings and disinfection procedures. A paradigm shift is needed to ensure reusable PPE becomes a standard part of everyday readiness, not just something we turn to when disposables run out. It is also critical that educational and logistical considerations be addressed via programs complementary to stockpiling of the products themselves. Building reusable respirators and other types of PPE into routine procurement and planning can dramatically reduce vulnerabilities across the supply chain. The third area is smarter stockpiling. The nation is putting a lot of effort into domestic manufacturing right now, but even the best manufacturing base can't help if stockpiles are not managed effectively. That brings me to a key point. We need to move beyond the traditional store it and hope we never need it model. Manufacturer-managed inventories or organization-managed inventories are smart alternatives. With manufacturers or organizations rotating products continuously, everything remains within its shelf life. That means there are no huge losses from expired stockpiled products. There are faster, more reliable delivery because inventory is already close to the end users, and the ability for manufacturers to surge production quickly when demand surges is available. Organizations that routinely use respiratory protection should be rotating their routine stock with their emergency stockpile to keep that stockpile fresh. Holding inventory is a financial burden to all parties. NIOSH recently published tips for managing PPE and stockpiles, and disseminating this information and figuring out how to get it to the people who need it is very critical. Modernizing PPE standards, routine use of reusable respirators as well as disposable, greater use of rotating inventory models, and establishing a central coordinating authority gives us a much more flexible and resilient preparedness system. If we take these steps together, we'll be far better prepared for whatever biological threat comes next, natural, accidental, or deliberate. And we are committed to helping make that future a reality. Thank you.
Thank you. Nicolette.
Thank you so much for having me. I want to apologize. I am coming down with something, so apologies if it's hard
This
to hear
is the
me.
right place.
I know, right? I wish I had a respirator right now. I first want to thank you for having this conversation, because as we are seeing various aspects of the geopolitical threat environment shift, it is important to continue to keep the role of the supply chain and the role of supply chain and biodefense top of mind. So it is incredibly important to have this conversation, and given that my co-panelists have covered so much already, I will just quickly try to move through some of the vulnerabilities as we consider what the landscape of the global supply chain looks like today, some roles that we see for the federal government and federal government partnerships, but also policy that would drive industrial-based strategies to enhance domestic manufacturing and secure some of the international supply lines. I think one of the very real operating realities of this is that if it were very simple to do, this would have already been done. And so acknowledging the complexities that exist, but also suggesting the policies and economic drivers that help to actually shift us towards a more ready posture are what we're seeking to do. As you said, I am the Chief Policy Officer of the Healthcare Distribution Alliance. HDA is about 149 years old and have been working with distributors in that time. So understanding the role of the supply chain and distributors is incredibly important to who we are and what we do, in a role that we take very seriously, moving about 96% of all medical products on a daily basis. And so as I lay that out, part of the reason that I think it's so important is because as we're thinking about solutions that involve the rotation of product in the supply chain and the movement of product to where it needs to get, distributors have to be front and center in that and play a very important role in thinking about how we continue to rotate this product on a daily basis so that we do not have a situation where we have expired product at the time where we need it the most. I also want to talk about the linkage that exists between the healthcare supply chain, between the pharmaceutical supply chain and the med-surg. I know this meeting is focused on the PPE supply chain, and it's critically important. I just would encourage us to not lose sight of the fact that in a moment where we need personal protective equipment, we very likely will also need medical countermeasures and other products in the pharmaceutical supply chain to sustain public health. And so as I saw that Twisted Sisters title, it is not lost on me that one of the twisted sister relationships that exists is the one between the pharmaceutical supply chain and the need to move product, as well as with med-surg and the need to move the equipment that we will rely on. We do know that the U.S. depends heavily on foreign sources for key materials and medical products. This is a result of a 30-year economic policy that it will be impossible for us to shift overnight. However, recognizing that adversaries can exploit the supply chain through various policies, export controls, trade restrictions, even targeted cyber attacks and physical attacks, it is important for us to think about how to harden infrastructure and diversify supply chains. However, also thinking about how we are thinking about strategic reshoring so that we are not over-concentrating our domestic reliance in maybe a particular state or a particular region is also important to this. So thinking about how we can actually maintain a sufficient level of geographic diversity while avoiding even a concentration in domestic landscapes to avoid additional vulnerabilities. While both on the pharma and med-surg side, I would point you to an example such as the flooding that occurred in North Carolina, where a North Carolina plant that produced about 60% of U.S. IV fluids was impacted, and it triggered nationwide shortages. So that's an example of why thinking about overconcentration is incredibly important. So as it relates to the recommendations that we would offer, we think that there is a critical role for partnerships between the private sector and the federal government, but we also think that state and local governments play an important role here as well. So as we're thinking about stockpiling, not just looking at the role of a federal stockpile, but also regional stockpiles. We've heard from states that having a state-run stockpile can be incredibly expensive, but regional stockpiles where states are working in a collaborative and thinking about the cost share and partnering with the private sector have a proven record of success and have been proven to be something that we can actually take forward and think about being able to rotate product as those states are working in a compact. As we're thinking about federal investment, also thinking about how federal investment can actually be targeted at low margin but essential products is critically important here, again, in an effort to reduce or undo some of the economic policy challenges that we've seen in the past. And then finally, I would just offer that the opportunity to think about vendor-managed inventory, thinking about allowing manufacturers and distributors to hold and rotate products so that the burden is not solely on the SNS or these regional stockpiles, can significantly expand our capacity and allow for us to have more product on hand and also forward position for deployment. Thank you.
Well, thank you. I've got a couple questions, and we'll pass the baton up here. Nicolette, you make a lot of sense when you talk about regional stockpiling. So I know us members, former members of Congress, when we experienced COVID, we were, for me, I worked with our congressional delegation, everybody, our governor, particularly our hospitals and major employers. Where have you seen regional stockpiling actually? I know the federal government is now trying to pass the baton to the states and locals. What specific areas have you seen where regions have come into play to say, we can help? I mean, where have you seen that across the country? Because I've not seen it in my district, at least at this point.
So we're starting to see that as the Northeast, the Northwest are forming public health collaboratives. This is one of the conversations that they're having with HDA and our members right now. What we've seen in the past are mutual aid agreements where one state might say, how can we work together in an event? But what we're trying to encourage them to lean towards are using these public health collaboratives that are emerging. Specifically, we are seeing one in the Northeast. We are starting to see the formation of one in the Mid-Atlantic as well, and as well as the Northwest. So I kind of have a map in my brain that I'm moving through. Those are the things that we're
Can I ask a question about the private sector and the hospital system? My impression is that a number of the big hospital systems are already stockpiling, that they sort of gave up on the fragmented approach that the federal government had, and that they're actually building their own stockpiles, so at least they can handle the initial.
Sure. So it's hard to speak in generalities, but I will do my best. What we're seeing is that a number of large hospital systems are thinking about a two-part strategy. One is actually thinking about increasing inventory levels. And so what that means is that they are holding a bit more product on hand. So for example, their days on hand may go from 7 to 14. It sounds small, but it creates an opportunity.
And they'll cycle it through, so they'll keep everything fresh.
So they are keeping that inventory on hand, but they are actually working with distributors to do that vendor-managed inventory strategy. That way, they don't have to necessarily many hospitals don't have the warehousing capabilities that would allow for them to do that VMI on their own. And so they're working with distributors so that the distributors are holding that product for them. There's a dedicated amount. In some instances, they're going to 30 days. Some instances, rare, but they're going to 6 months as well. And they're actually asking the distributor to hold and rotate that product that is dedicated supply for that hospital.
Victoria, I'll confess I had to go to my local hardware store, one of my favorite places, to buy an N95 mask a couple weeks ago. And I think I had to buy 3. I think the packet said I had to buy like 2 or 3 versus 1. I would have far preferred to buy 1 with multiple filters that I could clean. But I don't know that that's available to the average consumer, is it? I mean, this was pretty large. You know, these are the Home Depots and Ace and Lowe's. Do they sell filters, replaceable filters, you know, that the average consumer can? Maybe I just didn't look at the right aisle.
They do. I think they're certainly not, I would say, as common as this standard like disposable N95.
Yeah.
I think this is part of what makes elastomeric respirators kind of challenging to be part of the conversation. They look a little bit more like, I think, what you would picture as a gas mask. I wish I had brought one with me.
I did see them. Yeah.
If you saw the front page,
I didn't want to scare people in my house wearing that thing.
You know, I think that it highlights a really important point about what it's going to take for reusable respirators to be widely used, especially in industries like healthcare, where you do have pretty specific needs in terms of how a healthcare worker is presenting themselves. I think there are innovative reusable respirators on the market. You know, I could show you examples of reusable respirators that look quite similar to a disposable respirator. They're certainly not any scarier, and I don't think people would have any objection to a healthcare worker using them. They haven't made their way entirely into these kind of Home Depot shelves. They certainly do exist, though.
So my last question, and it goes back to what I first said this morning, I don't know if you were here then or not, but I talked a little bit about the funding of the national stockpile and how it had been almost $14 billion during COVID, and this last fiscal year was $980 million. I suspect that's what's in the CR now. I've not poured through the pages. Where are we in terms of where we should be in terms of not only respirators but also on, you know, the most simple tactics, that be the N95s? Where are we in terms of a percentage of what we should have in a stockpile today?
What should we? So, I think I can't speak specifically to what exactly is in stockpiles, federal stockpiles or stockpiles across the country. I think we have a long way to go, and for one of the reasons being what I mentioned in my opening statement, which is most stockpiling is currently targeted towards healthcare workers. So,
as it should be.
Yeah, I mean, I think as Nicolette mentioned, like we're seeing a lot of hospitals that have their own stockpiles. We see a lot of stockpiling efforts happening outside of the federal government, but by and large, the number of people who are going to need respirators to work in person in an emergency is, I think, much larger than people are aware. And it's not to say that they're more important than healthcare workers. I mean, healthcare workers are, by definition, the most frontline workers, but they're certainly not the only workers. Yeah. And right now, very few groups are even thinking about them as being the recipients of a stockpile.
Mm-hmm. Anybody else have a thought on that?
Yes, there are a number of both filtering face piece respirators and elastomeric respirators in the stockpile right now. During 2020, the SNS purchased about 750,000, or half of the 750,000 authorized elastomeric respirators that they plan to evaluate as a result of some studies that we did in the years prior to 2020 and 2021.
Thank you. Tom, do you have a question?
Well, thank each of you for coming today and giving us your presentation and the benefit of your wisdom and your experiences. I really can't think of a more compelling demonstration of the need for effective public-private partnerships than this. It just seems to me that it's an obvious challenge, but I'm curious if each of you could give us your appreciation of the importance of public-private partnerships and what would make a more effective one than the one we have today. What would you recommend on how we could improve the relationship between the public and the private sectors in creating these public-private partnerships. And maybe we'll just start with you, Nicola.
Sure. So I fully agree. I think public-private partnerships are very key here. The reality is that when we're thinking about especially an event that's going to touch any of the 50 states, we rely on infrastructure, and we're going to need that infrastructure that the private sector touches every day. So we're going to depend on the public sector policy, but it's going to have to be driven by the private sector. I think one of the largest challenges that we've seen is that when there are changes in administrations, when there are changes in policy, private partnerships have to reset with each of those changes. And so it is very difficult to have a partnership that sustains not just in the mechanics of the partnership, but in the level of detail and the granularity as it relates to everything from what information needs to be shared, the timeliness of that information, and what agreements exist as it relates to the roles and what would need to be deployed. So that is just one of the challenges that we've seen over time. I would say the other challenge, and this is something that I think is a real national security threat, is that the urgency of maintaining the partnerships wanes when there's not an emergency. And so there's a lot of resetting that has to happen every time there is a national emergency because we're not investing at the same level in that work in between events.
Thank you. Very helpful. Marianne?
Yes, if we look at NPPTL, in 2001 when we were established, our motto was quality partnerships enhance worker safety and health, and that motto remains today. We have very close relationships with the manufacturers, including the International Safety Equipment Association and the American Medical Mask Association, as well as HIDA, the Distributors Association. We also have very close partnerships with the unions, and firefighter unions, healthcare unions, and miner unions are our main areas, stakeholder groups where we work. And I think where partnerships need to be strengthened is when you look at things being pushed more to the states. I think our partnerships across the states could be strengthened, and we do have some now with key states that already have stockpiles, like California, for example, has a very fantastic stockpile and good maintenance of their products that are in the state stockpile, and a few other states do as well. But looking at how we build those partnerships across states, I think would be very valuable.
It's very helpful. Thank you. Victoria?
Yes, echoing a lot of the previous statements, agree completely. I think one of the most important elements is consistency. When you're thinking about pandemic preparedness, these boom and bust cycles of care and kind of neglect are some of the biggest challenges. I mean, especially thinking about, what we know about manufacturers and their needs. Getting this stable demand signal, both from users, from government, is really the only way that they're going to be able to be a partner. We're already seeing a lot of small manufacturers that are closing after the COVID-19 pandemic. These companies no longer exist. And so I think partnerships are meant to strengthen the industry as a whole and continue to basically allow these products to continue to exist when the next crisis occurs.
Thank you very much.
Jim?
Excuse me. In one of our very earliest publications, our blueprint from 2015, so 10 years ago, one of the recommendations was that urban areas and other regions should triage their hospitals and say that if in the event of a pandemic or bioterror event, that Hospital A would be, the patients would go there first, and we would pre-position PPEs and ventilators and so forth there, and then Hospital B and so forth in a very organized fashion. And I think largely that certainly didn't happen before the pandemic struck, and there's a recommendation we made considerably before that time. And from what I've been hearing from you, it's happening sort of ad hoc. This hospital is doing it, maybe this hospital system's doing it, maybe this regional area is doing it, but it doesn't seem like we're there yet, where there's some sort of, anybody could look at the whole system as a whole, the country as a whole, and say, okay, we're ready in that regard. And so I wonder if you could expand a little bit on why you think that hasn't happened and what it would take to really feel like we've got this thing beat comprehensively. And the other question is to what extent is it a problem that, and I assume that this is the way it works, if a hospital stockpiles a bunch of stuff, they're not going to get reimbursed for it until they use it, I'm assuming. You've got a patient has to need it, and then the insurer is billed for it, as opposed to they could spend theoretically millions, hundreds of thousands of dollars, millions of dollars to stockpile all this stuff, and it's just sort of sitting there, and it may never be used, right? So if I'm right about that, well, I should ask a question. Is that a problem? And if it is a problem, what needs to be done to transcend it?
I'll start with the reimbursement question first. So CMS has been looking at ways to reimburse for stockpiling. It is very complicated to do because a part of what I believe it was the 2004 HOPS rule tried to accomplish was to say every hospital could create a 6-month stockpile and they would be reimbursed for some portion of that stockpile. But the way that they rolled it out created a lot of concern because it would have also resulted in every hospital trying to do a 6-month drawdown from the supply chain at the same time. So trying to figure out how to get it right, I think is important. And also helping hospitals think about what they should stockpile and how much based on their community. And so we know that CMS is trying to figure this out, and they're trying to figure out how to prioritize hospitals. They have taken the view of starting to work with rural centers first, recognizing that their need would be greatest. But there are some initial conversations about how to reimburse, what that reimbursement picture should look like, and then what are the continued competencies that would have to be demonstrated to show that they are maintaining the stockpile at the level that it should be.
It seems like enough years have gone by since the pandemic that we'd be doing more than thinking about it, but the wheels of government turn slowly. I understand that.
Absolutely. I would just offer on the other piece that part of what is necessary to be able to figure out how hospitals and clinics and other centers would have to approach this would be a comprehensive threat picture. And so a threat assessment. And I think that's the part that is missing right now. And when you think about the financial picture that many hospitals are in, that is not work that they could take on their own or lead. And the investment in products, to your point, that would not be reimbursed would be very challenging for them to make in this financial picture. So without that comprehensive threat assessment and a clear alignment of what the roles of which hospitals or facilities would be, it's going to be very difficult for them to do this, except for the instances where a hospital can make the use case and justify the investment to be able to do this on their own.
It's pretty far down in the weeds, but if CDC reimburses a hospital for a piece of equipment, and then a year hence a patient uses it, are they permitted to still bill the health insurer for that? So that theoretically, they could get paid for it twice, and that would maybe be an incentive.
Yeah, I'd like to comment on that. So with the first topic you raised, which was, rural areas being able to move products around based on the need and such. In 2010, we initiated a project that was a supply chain management project for respirators, where we just did a pilot with Case Western, Emory University, and one other university. And the intent was to be able to monitor the products that they had in their stockpiles and know if there was a shortage, when you would be able to shift among the various organizations. So that effort then was scaled up to through a contract with the Center for Medical Interoperability, and the intent was to monitor respirators across the country and be able to shift them as needed. It would be a voluntary program where hospitals could contribute and participate and say how many products they had, what they needed at the time, and if there was a shortage during an event, they would be able to then get products from another location. Some hospitals didn't want to participate because they didn't want their resources being sent somewhere else. And then in 2020 timeframe, that project was actually canceled and never seen to the end. So I think when it comes to that type of effort, that type of thing, whether it's run by us or some other organization in the government, would be very valuable to have people voluntarily be able to participate in this type of effort and say they want to share their supplies if the need arose. So that's the first thing. The second topic you brought up regarding grants and being able to be reimbursed. FEMA had a program, or has a program, I think it's delayed right now, but the program is that they have grants that they offer to fire departments to purchase turnout gear and self-contained breathing apparatus. And they apply for these grants, they say why they need the products, and these grants are what funds their PPE that's needed. So building larger scale programs such as grant programs for healthcare institutions could be valuable that mimic the FEMA grant program and other types of, I think those are two recommendations I would have.
Thank you.
Yeah, those are some excellent comments. I don't have too much to add, especially on the reimbursement side. I think one thing I would emphasize is that in a wide-scale emergency, the demand is going to grow so quickly. I think one of the first points, if I'm correct, is like, why do we think these solutions have continued to be so sporadic, or why are some hospitals preparing and not others, and like what drives that to be the case? And I think that an inconsistent understanding of the risk alongside inconsistent resourcing, I think this is part of why we need to have a much stronger centralized planning, more centralized planning, since what we saw during the COVID-19 pandemic, community spread turned into COVID detectable across all 50 states within, I think, a couple of months. That means that demand is going to be extremely high, essentially from day zero across almost every hospital system. And so these sharing programs can certainly be advantageous, but in something incredibly wide scale, I still see that leaving many gaps.
Thank you.
Anna.
Thank you for your testimony, each one of you. And thank you, Nicolette, for coming and not feeling well. There can't be a worse combination of having to speak in public and feel lousy. So thank you for pushing yourself to bring your wisdom to us. I didn't quite get a clear answer. Are there any local, state, established centers for distribution now, or it's all being talked about?
There are local and state stockpiles.
There are.
Yes.
And are those part of the federal government's efforts, or the other ones that was being mentioned? I think Mr. Upton was asking the question about it, not knowing of any in his state or his region. I don't know of any in California or in my region, but there are?
Yes, ma'am. There are state-funded, state-operated stockpiles. I should also mention there are portions of the Strategic National Stockpile that are also forward deployed into states. But those are two
those I know
things.
of, the federal effort. Yes. But the public-private hospitals,
yes.
I think if there's certainly a picture in my mind of a glaring national failure was to see nurses wrapped with black garbage bags as their protective equipment during the pandemic. It just, I mean, I remember just closing my eyes. I didn't want to see it. I didn't want to deal with it. I think we all felt that way. What can you share with us, if there is anything, that has improved since then?
I could say that the Asper Industrial Base Exchange has a new name now. They have increased.
New name, and what does that
Asper
mean?
Industrial Base.
Well, I know what Asper is.
So Asper's program to build capacity in the industrial base has built up capacity for N95 respirators, surgical masks, gowns, and gloves, as well as melt-blown material that is used for filtering face piece respirators.
Are those all American-made products?
Yes.
They are. Yeah.
Yes.
I know that so many of the hospitals in my region They finally received their product, and it was worthless. It was just junk. In plain English, it was junk. It wasn't even usable. That's why I'm asking about American-made products. So overall, are you encouraged by what the system is now versus what we experienced and the, certainly the gaps in the system? I don't have a sense of good news here. But I'm also not so sure about what priority 1, 2, and 3 are relative to our supply chain and the product and the quality of the product.
I will say I am encouraged but extremely concerned. I think
So what are you worried about?
I think we are still talking about the issue, which I think is important. There has not been sufficient linkage of the economic and industrial policy with the national security policy in this space, which is to say, Victoria was talking about manufacturers that came online in COVID that are not able to sustain. That is not public health policy. If it were for public health policy alone, they would still exist. So I don't think that there are enough conversations about the full picture of this and how we got here and what are the policies that are going to allow for domestic manufacturing, strategic reshoring, sustainable stockpiling to be able to ensure. I think one of the things that we're seeing, the vendor managed inventory solutions, for example, that is something that can be a private sector solution and economically possible, but it's on the backs of what would be a long-term federal policy that still hasn't fully shifted. The investment dollars have to come from somewhere, and they have to last for 10 to 15 years to be able to result in meaningful change. And that's the part that concerns me, because the cycle, as Victoria said, the boom-bust cycle here is, I think, what many of us are holding our breaths to see, are we going to break?
The manufacturers, the domestic manufacturers that I met with and spoke to and maintained a relationship with several of them for a long time. They gave up their businesses because the product is made so much cheaper outside the United States. And I don't know how we're tackling that. I just, that it's just a bottom line thing. When I ask the hospitals, how could you, it's such a prestigious institution and whatever, how could you be buying this junk, this crap in plain English from China? And they said price. So, it drives so much. And I don't know if the domestic manufacturers who create the supply, how robust that industry is today. I don't have a sense of it except what you can share with us.
What I would just offer on a policy solution, and this has also been discussed in the drug shortages space with generic sterile injectables, where there's a challenge between the price and the resilience. Guaranteed purchaser contracts within the federal government can do a lot to increase sustainability. So when we're thinking about the role of the VA, where we're thinking about the role of the DoD, if there are guaranteed purchaser contracts that allow for federal investment to look like guaranteed business for these companies, that is a solution that helps them to stay in business.
Yes, strongly agree with that. I think the reality is that we've reverted to our pre-COVID behavior in so many cases, and the result of that is we're close to ending up not far from where we were pre-COVID in many ways. I think I wouldn't say that there haven't been improvements. There certainly have been improvements, but the reality is that we have not sustained the market, as you've said, and some of these domestic manufacturers just are no longer capable of producing at the point that they were during the peak of the purchases during COVID. I think manufacturers, one thing that stands out to me is that manufacturers tend to understand the need for preparedness more than almost any group that I've met. They're keenly aware of what the gap is and how challenging it's going to be. And I would just strongly agree that these consistent demand signals from government are one of the best ways for them to sustain their business. especially if these purchases are staggered over long periods of time. If you're thinking about filling a stockpile, not through one single year of purchasing, but 10 or 20 years of small, consistent purchases, especially for smaller manufacturers, this can be almost on par with their day-to-day selling of product. That's incredibly helpful for them to be able to maintain their manufacturing lines, to maintain their staff, to maintain trained staff to operate the manufacturing lines. It is, in my mind, one of the only things that you can do, considering, as you've said, the market is not really addressing this on its own.
If I could comment on that, from a respirator standpoint, 80% of the manufacturers who have the market share are still in business. So it's these small manufacturers who were startup during COVID. Some of them just wanted to make a buck, and they were fighting to get in this market. They weren't doing the studies necessary to make sure those products fit the users who were wearing PPE. So that's something important to keep in mind too. When you're developing a product, you should be undergoing fit testing with panels to make sure that product is going to fit a panel of individuals across the nation, not just
manufacturers that I referenced in my particular, what I shared with you don't fit your description. They'd been in business. They were small companies. They were small U.S. companies, and they made good products, but the price was, But I'm sure that there were many that saw they could make a buck, so they were out there too. But it was more what was coming into the country that wasn't American made that was really the junk. I mean, so, well, thank you very much. I hope you feel better too. Thank you.
Questions? I think I'm good, thanks.
No. Can I just add something else? You have at this, Marianne, your surname is a somewhat famous name in the country because it's the maiden name of the former Speaker, Pelosi. This is Nancy D'Alessandro. And Victoria, we had an outstanding member of Congress by your surname, Louise Slaughter. So, Nicolette, I've got to think of something.
Got to work on that.
Thank you.
Asha. Oh, Asha, I'm sorry.
Just a few. Marianne, you have talked about the challenge to do with counterfeits. Most people, when they hear counterfeits, they immediately jump to pharmaceuticals. But we have counterfeit all kinds of things, counterfeit bullets, counterfeit rifles, and now we're talking about counterfeit PPE. One of the lead investigatory agencies for counterfeits is actually ICE. But as we all know right now, no matter how we feel about it, ICE agents are being pulled off into immigration and much less into customs enforcement and the counterfeit investigations. We don't have a whole lot of investigators sitting in FDA, but we do have some. So we have this greatly reduced law enforcement arm that might be addressing counterfeits. What recommendation do you have to, to people who are receiving this or other folks that aren't going to be able to investigate necessarily? What recommendations do you have for identifying those counterfeits in the absence of law enforcement?
So I could say that from a respirator standpoint, we are monitoring the online marketplaces and the borders. We're working with Customs and Border Protection to make sure that they are capturing those products at the border that are counterfeit from a respirator standpoint, and then monitoring these online marketplaces. Amazon and eBay have been the largest, I don't want to say violators, but they have been the two companies where we have found the most counterfeit products, and we're working very closely with them, and they have removed hundreds of products off their online marketplaces that we have found to be counterfeit. So I think what I would recommend is that before you go to Amazon or eBay or any of these online marketplaces, Alibaba, to purchase any products, that you make sure you look at our certified equipment list if it's a respirator, to make sure that product conforms specifically to those requirements that are in our certified equipment list, because most recently we conducted a counterfeit study looking at respirator cartridges and canisters, and those cartridges look, I wish I would have brought some, but they look identical to those products that are authentic. And unless you had them side by side and just saw the little word that was missing, you wouldn't know. And we recently conducted a study to look at those, and 220 out of 240 that we evaluated didn't even come close to meeting requirements, but they look identical. So I would say be very careful when purchasing from these online marketplaces and look at the certified equipment list.
And we need to hope that NIOSH continues to be funded and can provide that list to everybody to look at. Victoria, the Commission is a fan of Blueprint Biosecurity and has read the reports that have come out, including the ones that you referred to today. And we understand the technology advantages for the elastomerics and the PAPRs. But the Commission has also heard from a number of folks that they're not fans, they don't want to use them. There's been enormous pushback. So how are you all addressing that? Because it's not, nobody's coming back and saying, the science and technology is just not there. They have other reasons for that.
I think it's an excellent question. I think, so going back to one of the points that I made previously, I think people first are not always familiar with the range of respirators that are available to them. When people think about an elastomeric respirator, a reusable respirator, maybe at some point they've used a respirator that was very uncomfortable because it was the only one that they had on hand. And I think I would emphasize that that's not the case for all of the respirators that are available, even today, not to mention the ones that could be developed. I think I would imagine you're speaking largely about healthcare. I think it's a very diverse pool of people. I think it's completely understandable that there is pushback to people who do not want to use a reusable respirator on a day-to-day basis. I think there are certainly hospitals that do it well. I think I believe University of Maryland Medical Center, Texas Center for Infectious Disease are a couple of hospitals that have a full-time elastomeric program with healthcare workers that report that they love using their respirators. That said, the goal of respiratory protection is to work for the worker. I think that there is a difference you have to make between what are people using on a day-to-day basis and what are people using in the height of a shortage. Healthcare workers also do not like sterilization programs in many ways. To get a respirator back that's not theirs, that's been worn by someone else. I think all of these programs have pros and cons. They're all important tools in an emergency. But from my understanding, having reusable respirators at the period in an emergency when fear is the highest, when uncertainty is the highest, when fear of infection is one of the most weighing things that a healthcare worker is facing, reusable respirators are consistently rated to be to have like higher perceptions of safety. I think for other concerns, so things like storage protocols, cleaning protocols, which can be pretty enormous, I think I would point to the researchers that have done some excellent work to establish these problems are solvable. There are programs that have been implemented that show that you can run these programs in an emergency. And like I said, I think that the biggest call is healthcare workers need more comfortable respirators.
Yeah, so it's not just the healthcare workers, it's the critical infrastructure, or the critical infrastructure folks that that we're hearing are pushing back. So there's a big concern really, even if somebody were to purchase for them, there's a concern about compliance. So a beautiful, spectacular PPE that would protect you against anything and everything, if not worn properly or consistently, is like not wearing anything.
Yes.
So thank you. Nicolette, we talk a lot about diversifying supply chains, securing supply chains. Can you talk about the possibility of diverting supply chains?
Sure. So there's been a lot of work in supply chain integrity done over the last 12 years in particular. The work to secure supply chains, meaning that end-to-end. Products are traceable. The track and trace work that we've done, that you can identify when there may be a diversion, is ongoing, and frankly, it's work that has to happen every single day. There are concerns around theft, and I think in a public health emergency, the risk of theft that would lead to gray market, black market sales is something that we are incredibly apprised that we have to use those mechanisms. There is something that is called the Pharmaceutical Cargo Security Coalition that actually exists under HDA's banner now, that solely does this work day in, day out with manufacturers, chief security officers, across the supply chain, with distributors and with law enforcement every day. And so there is an effort to make sure that there is this coordination that's happening with the recognition that there is a risk of product being diverted. I would say, just putting it simply, it is a lot harder for counterfeit product to enter the legitimate supply chain. So we make sure that we secure those paths, but also making sure that if product is stolen or there is some sort of diversion out of the supply chain, that we can identify that product and secure it as quickly as possible so that it does not end up in the black or gray market.
Is there ever a situation in which decisions are made to intentionally, instead of going in this direction, to go in this direction and go around something? Not for dastardly purposes, but because we've decided that it might be safer to go, to divert the supply chain and move it, or does it just stay the way it is? Period.
Yeah. So I think so in terms of product movement, like what happens with finished product, there are all sorts of decisions that happen as it relates to, for example, ship or air. There were Panama Canal or Suez Canal issues that have happened where there have been route changes. So those things do happen. But in terms of how the product is moved and tracked, there is always a tracking of that product. So those decisions are made. Those are company by company decisions, depending on who has custody of the product at that time. And in an emergency, it may be something as simple as, which is costly, but moving products by air and freight versus moving it by ship, or doing this in partnership with other product that needs to move because of a speed consideration. So those things do happen and happen on a fairly consistent basis.
During COVID, though, the federal government would intervene in the process and take over the PPE that a hospital system had ordered or a state had ordered.
Yes. So there were a couple things that happened in COVID. One was the partnership with the federal government, specifically the DoD and FEMA, to actually move product that was American intended product to the United States through Project Airbridge. And so that is kind of one time where you do see the product move in. And then as a part of that, there was a prioritization cell that FEMA set up based on the number of cases per county that were used to allocate product.
Thanks. And we'll follow up with you later about this issue to do with strategic reshoring.
Sure.
It's too deep to go into right now, but we need to talk about that.
Yes.
Thank you.
Panel 4.
Okay. I thought,
Oh.
yeah, we're done.
Yeah, let me thank the panelists. You were all extraordinary. Thank you very much for coming and for educating us. And now we're going to skip the break, and Senator Daschle is going to chair the next panel.
Well, thank you, Donna. And again, let me reiterate the chair's gratitude for your presentations and the answers to our many questions. We really appreciate it. And above all, thanks for your service. And I thank each of you thanks so many of you for sticking with us the entire day. Our final panel is entitled Finishing First. The title of this panel addresses the critical last mile failures of getting federally owned assets to end users at the state, local, and tribal, as well as territorial levels. We have an esteemed panel of speakers here with us today to discuss the issues regarding stockpiling medical countermeasures, managing supply chains, and ensuring communities get the assets they need during a biological crisis. We want to welcome and thank our final panel. Dr. Saira Mudad is the Chief Biopreparedness Officer and Senior Director of System-Wide Special Pathogens Program at the New York City Health and Hospitals. Our second expert is Dr. Meredith Allen. She is the Vice President of Health Security at the Association of State and Territorial Health Officials. And finally, we are very fortunate to have the benefit of the expertise of Dr. Julie Swan, who's the department head and a Douglas Allison Distinguished Professor at Fitz Department of Industrial Systems Engineering at the North Carolina State University. So we thank you very much for being here. I don't know if Dr. Swan is here yet or not, but I know she was here earlier, but we will start with Dr. Mudad. Thank you for being here.
Wonderful. Thank you so much, and good afternoon to you all and to everybody in the room. It's great to be here with you all, and thank you for the opportunity to testify today. So as just mentioned, my name is Saira Mudad. I'm an infectious disease epidemiologist and special pathogens preparedness response lead. I've spent my career working with public health and healthcare systems in the United States and abroad on biopreparedness, including PPE policy, and putting it into practice actually at the bedside. Today, I'm drawing on that experience across health systems nationwide with New York City as one case study. During the COVID-19 pandemic, PPE and the supply chain were not abstract concepts. They were the difference between a nurse feeling safe enough to walk into a room or not, between a hospital unit staying open or closing beds, between a clinician staying protected to care for patients or becoming a patient themselves. I'll focus my remarks on vulnerabilities in our PPE supply chain based on hard lessons learned from lived operational reality, and I'll ground them in 3 key messages. 1, any PPE strategy that ignores human behavior will fail. 2, frontline staff must be part of PPE design, selection, and policy. And 3, regulatory and policy frameworks must be aligned and consistent so individual hospitals aren't forced to improvise in a crisis. As we know all too well, COVID-19 didn't create vulnerabilities, it exposed them. In January 2020, as reports came from Wuhan, health systems proactively placed large orders for PPE in anticipation of a surge. We did what preparedness doctrine tells you to do: anticipate, order early, use data to protect burn rates, and yet the reality was very brutal. Orders placed became orders never filled, shipments promised became shipments that never arrived, and manufacturers locked allocation at pre-COVID levels based on the prior months of usage, while PPE use was tripling and quadrupling and more. By April 2020, our health system was using roughly 3 times as many masks and 6 times as many gowns as in January, while also adding thousands of temporary staff and increasing ICU capacity by 75%. That combination, exploding demand, and a frozen supply pushed the supply chain to the breaking point. From our experience and that of other systems, the vulnerabilities are clear. We relied on a thin, globalized, just-in-time supply chain with little visibility into capacity or allocations, limited surge capability for specialized items, quality issues from non-traditional vendors, and weak links between real-time burn rate data and manufacturing. I support a just-in-case, not purely a just-in-time approach, but stockpiles only work if they're well managed. During COVID, many failed in predictable ways: expired or degraded supplies, the wrong products arriving, slow and opaque allocation and request processes, and data systems that couldn't answer basic questions like how much was actually in your stockpile. To make stockpiles truly strategic, we need action at every level. Federally set minimum PPE standards, align NIOSH and FDA, keep the strategic national stockpile at transparent backstop, and use purchasing power to anchor domestic manufacturing. States and tribes should maintain regional stockpiles tied to healthcare and coalitions, coordinate allocation through multi-agency centers, and build real-time inventory systems that reward reporting. Locally, health systems must keep surge-ready caches, strengthen logistics and quality checks, and fully integrate PPE into surge planning and training. If you rely on someone else's stockpile, you must be able to trust that what arrives is intact, appropriate, and on time. And that reliability should be treated as critical infrastructure. Let me turn to PAPRs and elastomeric respirators as potential alternatives to surgical masks and N95s. Elastomerics are highly effective for pandemic preparedness. They're most cost-effective during heavy use, generally fit better. A single model can fit most staff, and unlike constantly changing N95 models, they can be reused for years, easing training, fit testing, and logistics. They also have a long shelf life, making them ideal for stockpiling, and cleaning protocols are established, with several models now NIOSH approved for source control and specifically designed for healthcare settings. So in other words, from a technical and an economic perspective, elastomerics are an excellent tool in our preparedness toolbox. But this is where my experience in actually operationalizing these devices comes in. PPE lives or dies on human behavior and workflow. We saw this clearly with N95 decontamination. On paper, reuse looked like a smart conservation strategy. In practice, many staff were uncomfortable wearing a decont mask that had been on someone else's face. The drop-off here, pick-up there workflow was complex and error-prone, and in a high-stress environment, tracking, labeling, and retrieving specific respirators added cognitive load to people who are already exhausted. The lesson is simple. If staff don't feel safe, or if the process isn't simple, it will collapse. The same behavioral and operational questions apply to elastomerics. Who is responsible for cleaning and disinfection? And is there clear guidance on products and contact times? And how do they affect communication, comfort, and stigma? Can staff be heard by patients? Can they tolerate them wearing for extended periods of time and feel they're acceptable in different cultural and care settings? For PAPRs and cappers, there are added challenges. They're expensive. A single capper can approach $1,000 before replacement parts, require intensive training to avoid self-contamination, and need clear plans for decontamination and maintenance. Just as importantly, the role must be clearly defined, whether they're reserved for aerosol-generating procedures or used more broadly. So would elastomerics and PAPRs help in future emergencies? Yes, absolutely, if we do three things. First, design and select them with frontline staff at the table. Don't just ask, does this meet the standard? Ask, will you actually wear this for 12 hours? Can you do chest compressions in it? Can you talk to a scared family member in it? 2, build the operational ecosystem around them before the next crisis. That means defining cleaning workflows, staffing for reprocessing, storage, tracking, and clear guidance on when to use which device. These aren't just pieces of plastic and filter media. These are actual programs in hospitals that require a lot of time and effort. And 3, align regulatory guidance on approval, decontamination, extended use, and reuse. So let me close with 3 concrete recommendations that arise from all of this. 1, center behavior and trust in PPE policy. Any advancement in PPE, be it elastomerics, PAPRs, cappers, or a new decon technology, must explicitly account for whether frontline staff feel safe and are willing and able to use it correctly over long periods. Human factors are not a soft add-on, they are mission critical. 2, bring frontline staff into design, selection, and policy making. Respiratory therapists, nurses, environmental service workers, physicians, paramedics, those who are actually wearing the PPE day in and day out should be at the table helping evaluate new devices, pilot programs, the decon workflows. If they're not comfortable in it, it will not work in the real world. And lastly, 3, align regulatory requirements and provide clear national guidance on crisis standards. Ensure that PPE use in healthcare is appropriately NIOSH approved, that devices used in outbreaks provide two-way protection, and that there is consistent pre-established guidance on decon, extended use, and reuse, so we don't have thousands of healthcare entities, like we did during COVID, making it up on their own for the next emergency. So if we do these three things, embed behavioral science, elevate the frontline voice, and align regulations with operational reality, then investments in domestic manufacturing, stockpiles, and advanced PPE like elastomerics and PAPRs will actually translate into better protection on the ground. Thank you.
Thank you very much, Dr. Modad, for an excellent presentation. Dr. Allen.
Good afternoon. Thank you for inviting me to provide some remarks on behalf of state and territorial governmental public health.
You mind just bringing the microphone a little bit closer?
Sure. Is that any better? Great. I represent ASTO, the Association of State and Territorial Health Officials. We are a nonprofit membership organization supporting the work of the chief public health official and their leadership teams in states, Washington, D.C., U.S. territories, and freely associated states. I'm the Vice President of Health Security at ASTO and lead an outstanding team of public health professionals with expertise in preparedness, environmental health, infectious disease, and immunization. Our team at ASTO supports numerous programmatic and leadership activities within state and territorial public health agencies, but the most relevant for us here today is our Directors of Public Health Preparedness and Medical Countermeasure Coordinator groups. The DPHPs, along with their MCM coordinators, lead the state's public health preparedness programs and are responsible for planning and leading response efforts. The remarks I'll provide today are not only informed by our staff at ASTO, but also the DPHPs who coordinate across government, industry, and their communities. Today, I would like to focus on 3 areas that will impact our preparedness to respond to numerous health threats in the years ahead: the global supply chain vulnerabilities, the role of federal and state governments in stockpiling, and policy and industrial-based strategies needed to strengthen our national resilience. The public health impact of ongoing shortages of essential drugs and medical supplies is significant and continues to undermine our ability to treat both chronic everyday conditions and emerging health threats. A recent study of health system pharmacists survey showed that there were severe shortages and 97% of respondents had to substitute therapies, 85% of them rationed care, and nearly half had delayed or canceled treatment altogether. The lack of domestic economic incentives continues to hinder the maintenance and expansion of the current domestic market, including the development of any new therapeutics. Due to low profit margins, primarily for generic drugs, manufacturers have few incentives to maintain, let alone expand production, and it often correlates with shortages. During infectious disease outbreaks, challenges with internationally dependent supply chains may be magnified by the unpredictability of the outbreak of any kind of highly transmissible agent. Second, it's really important that we clarify the roles of federal and state governments in building and maintaining medical countermeasure stockpiles. There's an ever-changing expectation for state and territorial health agencies to maintain and build these stockpiles at the state level or regionally. For states to accurately plan and utilize diminishing resources in the most effective way, they need to have a set of minimum planning guidelines for strategic national stockpile countermeasure support. This includes an outline of the scope of the SNS, including what can be expected upon request, along with timelines and triggers for federal assistance. While it's necessary for the national stockpile to continue to evolve with the changing threat environment, new treatments, and new technologies, it's equally as important that this information is communicated with states and territories so they can adjust their planning assumptions and assure that any state or local stockpile is complementary of the national stockpile, not duplicative or even worse, full of gaps limiting our capability. The inclusion of states or even representation of states in the Public Health Emergency Medical Countermeasure Enterprise, or FEMC, would allow states to have input into and better visibility of the current and future federal medical countermeasure asset and program. We're excited to begin conversations within the FEMC and to share jurisdictional feedback for their increased awareness with a goal of increased bidirectional education and communication. We're soon expecting to receive from SNS a document detailing items that are available in the SNS to aid in this needed clarity, and it's a good first step toward building a more cohesive stockpiling approach between the state and federal government. Additionally, states and territories need federal partners to issue clear prioritization and allocation strategies for the PPE and other countermeasures that are available, and provide further clarity on the allowable use of federal funding to support state stockpiling. Federal funding, specifically FEP and HPP funding, continue to be the main source of funding for state and territorial preparedness planning. Funding uncertainty, both at the federal and state level, is a major challenge to jurisdictional stockpiling. Stockpiling is resource intensive, requiring procurement, maintenance, and security of warehouse space, procuring new and rotating out old assets, maintaining medical equipment, and staffing. An extension of federal purchasing contracts and incentives to state and territorial health agencies for items no longer supplied by the SNS would allow states to stretch the existing funding further. Due to funding concerns and the expense required to maintain state stockpiles, it is worth noting that some states are beginning to dismantle their state stockpiles post-COVID. As an aside, there has also recently been an interest in moving additional responsibility for emergency responses from the federal government level to state and local jurisdictions. States are capable of taking on additional responsibilities. However, they need additional funding to be able to increase staffing, add specific expertise, and grow stockpiles, among other activities. It's important to note that these special circumstances and unique challenges of our territorial members, for example, there are special challenges in identifying reliable vendors, both domestically and internationally, for their individual needs. States are tackling stockpiling through a variety of different policy mechanisms, including law and proposed bills that establish state-level stockpiles, add additional items to their stockpiles, modify the management of stockpiles, and create flexibility around product expiration extension and product use. Some states have modified their emergency contracting laws to allow for more flexibility in a response and hopefully reduce the need for stockpiling. State public health agencies continue to work with the public health and healthcare community within their jurisdictions to ensure partners are aware of what potential federal and state stockpiles exist and what resources are contained within them. It's vital that healthcare facilities understand when they should purchase their own supplies and what types of products may be able to be requested from a state or federal stockpile. Further complicating the issue is that not all jurisdictions should stockpile the same items. It's important to recognize how differing regional risks from rural areas to major metropolitan centers shape those stockpiling needs. Individual state and/or regional assessments are needed to continuously update and inform any jurisdictional stockpiling efforts. Third, we have critical opportunities in policy and industrial-based strategy. Reauthorizing POPRA is essential to sustaining preparedness programs across the country. The nation also needs renewed funding for the HHS Supply Chain Resilience and Shortage Coordinator, whose funding expired in May of 2025. Expanding our STEM and manufacturing workforce pipeline is equally as important, as is ongoing engagement with state partners to ensure that policy and operational decisions are aligned at every level of government. Taken together, these issues highlight the need for sustained attention, stronger coordination, and targeted investment in jurisdictional preparedness and stockpiling. I'll close with 3 actionable recommendations that could move us forward. We would recommend establishing a jurisdictional committee of experts to develop shortage mitigation plans and conduct regular policy and capability analysis. This committee should include a variety of public health, clinical, legal, and ethical subject matter experts from across levels of government and industry. We also need to look at expanding public and private partnerships that enable innovation in funding, contracting, and inventory management across federal and state levels. And finally, prioritizing risk-based stockpiling strategies tailored to the unique needs, constraints, and vulnerabilities of each region. By confronting weaknesses in our supply chains, increasing communication and transparency between federal and state stockpiling programs, empowering state and territorial preparedness partners, and strengthening our policy and industrial foundations, we can build a strong, resilient, and prepared approach to stockpiling for the nation. Thank you.
Thank you, Dr. Ellen. Dr. Swan.
Thank you. Am I close enough to the microphone for you? Commissioners, fellow panelists, other guests, thank you for inviting me today. I would also like to thank you for the important work you've been doing with the National Blueprint for Defense, Biodefense, and the associated Apollo program and Athena agenda. My notes today are available for those who want them at golink.ncsu.edu/biodefense. That's for those of us who like to see written things, not just hear things. That's GoLink, and the last is Biodefense. I would like to start with a blunt reminder from the Gates Foundation. Developing and manufacturing a vaccine is only part of the solution. The Gates Foundation goes on to emphasize logistics and delivering to everyone, reaching the entire population, and doing so equitably. My core message today is simple. Biodefense succeeds or fails in operations, in supply chains, and the last mile. I have several findings I'd like to talk about in areas of potential improvement. Finding 1, our biodefense supply chain is operationally fragmented, and fragmentation can lead to lack of alignment and critical failures. The U.S. public health system is decentralized with many decision makers, which makes it inherently hard to align incentives, procurement, data, and distribution decisions across federal, state, and local levels. Why this matters? In a crisis, fragmentation produces critical gaps in information, competing priorities for allocating scarce resources, duplicative buying and competition for scarce items, slower distribution, and uneven outcomes. If we want speed and equity during the next emergency, we need pre-aligned playbooks, roles, and interoperable information systems, not ad hoc coordination. These playbooks should apply to a range of threats and countermeasures, and they should be regularly updated. Second area, we repeatedly build countermeasures without defining the delivery system that makes them usable. There's a disconnect between some of the development of medical countermeasures and the operational reality around the cold chain constraints, minimum order sizes, administration's requirements, especially for treatments. These are often treated as downstream details, but they are system defining. We also lack an end-to-end understanding of dependencies, including from vaccine components upstream to unsexy items like pipettes for testing. This fog of uncertainty drives shortages and competing procurement. The implication is that we need to treat delivery requirements as product requirements, thinking about the operations and the last mile when designing them. In addition, we must map the full bill of materials and capacity constraints across the network, across companies, before the next crisis. Third area, the last mile is not a footnote. It is a decisive battlefield. Even when product exists, last mile distribution and administration sometimes break down because distribution systems for scarce resources are hard to design fairly and in ways that promote access for all. Reaching high-risk populations can be operationally difficult. Objectives compete under scarcity. Misinformation and disinformation erode uptake, and data systems are insufficient throughout the system. A new vaccine or a stockpile without a last-mile operating plan is not readiness. We have to invest in delivery capacity, trusted messengers, communication strategies as core biodefense infrastructure. We must restart research related to misinformation and disinformation and have a targeted effort to address communication by the government in collaboration with partners. Area 4. Modeling can materially improve decisions, but only if the data and interfaces are ready before the emergency and if diverse groups can participate. During COVID-19, modeling groups collaborated through efforts like the Scenario Modeling Hub, producing ensemble forecasts and projections. Modeling helps identify higher risk settings and populations and assesses mitigation strategies, including non-pharmaceutical interventions. Our team's work showed the potential to capture the impacts of vaccine distribution priorities on diverse populations and the importance of partnering to increase uptake of vaccine. But one persistent barrier is timely access to accurate standardized data, which includes on cases, tests, hospitalizations, and deaths, and the operational data needed for supply and delivery decisions. Preparedness means building the data pipelines, governance, and partnerships and not trying to invent them mid-crisis. Preparedness also means leaving room for innovation as new approaches in modeling arise and new modelers bring fresh perspectives. Area 5. Schools are a canary in the coal mine for biodefense delivery. Keeping them open safely requires layered, logistics-heavy mitigation. I would like to highlight congregate settings like K-12 schools and universities. They contribute to the spread of disease. Countries that successfully kept them open used extensive non-pharmaceutical interventions and countermeasures such as rapid testing and masks. Mitigation is critical in congregate settings, and the full range of measures includes masks, testing, ventilation, and more. If our plans can reliably support schools through supplies, testing logistics, staffing, ventilation upgrades, clear decision rules, and communications, then they're more likely to work for other high-throughput community settings as well. They can be treated as an operational stress test for readiness, not as an afterthought. And truly, as the song says, children are our future. What I would do next. First, sustain investment in public health infrastructure, information systems, and personnel, federal, state, local, and internationally, because global emergencies become local quickly. Institutionalize collaboration across public-private academic partners for research and development, planning, operations, and evaluation, including sustained support for modeling, data, and decision interfaces. Number 3, map the full countermeasure supply chain end-to-end, including the components and the boring dependencies. Stress test the vulnerabilities and resilience across multiple threat types from global supply to local operations. Right now, we don't even know what we don't know because we don't have an inclusive view of the system. Number 4, plan explicitly for multiple subpopulations and delivery channels. This includes understanding exposure risk, transmission contributions such as congregate settings, and that vulnerability differs by pathogen. Schools and universities, for example, require layered mitigation strategies to prevent rapid spread. Number 5, fortify the last mile with communication and counter misinformation planning, including operational playbooks and research-backed approaches to improve uptake. We've shown that we can do remarkable things. It includes rapid development of safe, effective vaccines, massive scale-up, and millions of lives saved through medical countermeasures and mitigation. Now we have to ensure that that progress is not lost. Biodefense readiness is not only about what we can invent or stockpile, it's also about whether we can deliver it fast, fairly, and at scale. A countermeasure that can't move through the system is not a countermeasure, it's a warehouse artifact. Thank you.
Thank you, Dr. Swan, for an excellent statement. I have some questions, but Don, I know you have a schedule, a tight schedule. Let me turn to you first for your questions.
Let me ask whether there's a model state whether or states that are actually doing this. I mean, I assume you'd say New York City at least is building the infrastructure, but when you look across the country, Alaska, Hawaii, who are beginning to do it right?
I think there's a saying in public health that you've seen one state's public health system, you've seen one, and that's really it. They are extremely diverse in probably every form that you can imagine. New York City specifically has a level of resource that many states themselves don't have, and I think it's important to recognize that. But then I think they are also preparing for different things than some of our rural states are. And so looking at the differences in preparedness programs and the ability to respond is really looking at what are they actually planning to respond to. I think all states are really working quite hard towards really increasing partnerships, and I think that's become even more important in our resource-low environment at the moment. But I think that there is no one state I would point to. I think that they've all got different and unique aspects that they've been able to build up. And through ASTO, we have the ability that we bring them together in such a way that their preparedness planners meet on a regular basis. There's actually a call this afternoon where they do share their resources and share best practices with each other on a routine basis. They talk about planning that they've done together, and they do look at the approaches that they can take regionally or even across the country in ways that they're able to support each other.
Thank you. Dr. Swan, you're very rational. I can tell you, you're an engineer, a systems engineer.
Future HHS secretary.
Yeah. If you had one recommendation, I mean, the system is so fragmented now, and we really don't have an overall system. If you had one recommendation that would make a difference, what would it be?
A data information system end-to-end. In the last pandemic, the federal government has visibility to when the product goes out the door at the warehouse centrally. And then there's a gap because there's no data again until it shows up on an administration, we've given this many doses out. And that's a gap of several days or more, and that's just one example across a wide range of things related to data and information.
Mm-hmm. Okay. I yield back.
Thank you, Donna. Well, let me just pick up with your answer to that question, because it seems to me that as we look at building an effective stockpiling infrastructure, my perception is that the two of the most important factors are a real emphasis on good communication and an extraordinary determination to find and build a distribution system, especially in the last mile. It seems to me that communication and distribution are essential. First, I'd like to ask each of you if you would agree with that, if you'd add something, and if so, how do we accomplish better communication and better distribution given the fractured system we have today? Let me begin with you, Dr. Swan.
I think you're exactly right that communication is critical. And what we saw during the recent pandemic and in other settings is that misinformation and disinformation are rampant and are having significant impacts on our ability to mitigate biodefense threats across the board. We do know that trusted partners matters, and that is one element of communication, but I think that we do need to do more to actually counter the misinformation and disinformation that spreads quite widely. You're right about distribution. Now, when we say distribution, of course, it's not the transportation itself that's the issue. It's really from when it arrives in a state until when it goes in an arm or somewhere else. And that is a significant undertaking that can change during the course of the pandemic as well as across different kinds of threats. There's not just one solution to that. I do think that there's more than one, but I do think that partnership is an important part of that, partnership between public health agencies and hospital systems and private companies and others as they're trying to get the vaccine out quickly across a broad population.
Dr. Allen?
Great. To add on to that, I think, I absolutely agree as well. I think communication and distribution are at the heart of the issue here. Communication specifically between different levels of government, from federal to state to local. There have been instances where, resources were shipped from federal agencies and the state didn't know it was coming, or didn't know what time it was coming. And so the communication not only around the actual logistics of the information, but also what type of product is available, when it can be requested. There's a lot of things that need to improve around communication, but then also communication with the public from state and local health agencies as well, directly to their communities. And I think a lot of that in the mis and disinformation that we've seen, but also increasing trust in the public health system and what the actual recommendations are and that they're science-based, I think is important. Distribution is one of the issues that public health, I think, struggles with, is the scalability of it. To be able to maintain the workforce required to do a distribution in an emergency at that level across the communities is a huge workforce and a huge number of people even just required to do that. And kind of, you heard in our earlier panel a little bit about the boom and bust cycle of funding that public health has experienced. It makes it very challenging to maintain kind of that warm base level of staff that are able to train up folks to be able to participate in distribution efforts at the time of emergency. So I think those are things that also need to be addressed as well.
Thank you, Dr. Allen. Dr. Madad.
I would say I think one of the missing pillars there is trust. And, dare I say that we have a problem of just overconfidence and looking at sharing supplies. Oftentimes what we see is we get this false sense of security that, we have the stockpile at the state level, at the federal level. And so when we're in a bind, we can tap into those resources because they exist. Even our own stockpile, maybe you may have something, that's just a few miles down. But what happens is when you actually order some of these supplies, the communication sometimes is there, but then what you order is not what you had discussed. As an example, we've seen this time and time and again. You ordered pediatric surgical masks, but you got were adult masks. We communicated we wanted pediatric masks. Well, we thought we sent you that, but that's not what arrived. You get expired PPE, or you get PPE that's degraded. We've seen this time and time and again. So the problem is you can have stockpiles, you can have communication, you can have the distribution channels, but that trust is not there. And we need to make sure that what we are ordering is actually what we are receiving, because what happens is when you are relying on that stockpile, then you're not putting in bids because you think that that asset is there. Once you get it, even if it comes on time, if the product is not what you anticipated, then now you're in a bidding war with everybody else. And we've seen that from outbreak to outbreak to outbreak.
Appreciate that very much. Fred?
Well, thank you. You make me almost want to wish that I lived in North Carolina. Dr.
We'll take
Swan.
you. Come on.
No, I'm happy in Michigan. How many states, how many states have a game plan, a textbook, a blueprint along the lines of what you wrote? And is there, as you think, I know you're North Carolina State, right? University. So is there an association? Do you interact with peers across the country? Could we have someone from Arizona or California like you here and would have given us the same type of presentation in terms of thoroughness and really accountability in terms of what the states ought to do?
Well, there can be only one, so I'm not going to say they're going to bring the exact thing, but yes, there are other people like me who look at supply chains and emergency response. Every state was required to have a game plan. It was submitted to the CDC initially around July 2020 and then a follow-up in October 2020. I went through and read many of those, and it is just like Dr. Allen says, they're very different, and there's strengths of different states across that. In the last pandemic, everything changed around January 2021. And so to some extent, some of those playbooks got thrown out because a change happened. And so that led to some additional things occurring. But I think also there are sometimes gaps between what you plan and what reality is, because as you scale up and it's a complicated system, it's really hard and you don't think through all of the aspects. So one of the things that is sometimes not talked about much, but when there are scarce resources, how do you determine who's going to get an appointment to get that? And in a lot of states, it boiled down to who could sit at a phone and call for hours and hours. Right? And so there are ways that you can deal with that operationally, but a lot of states didn't think about that in advance. And that's, sort of a second order effect. First, they're trying to figure out how do I move this and stand up clinics to get things scaled quickly. So there are groups that look at the coordination. There are academics as well and mathematical modelers, and we do talk and share ideas and those kinds of things. There is sometimes a gap between what's being done, let's say, in academic or in states and what might be coming out of federal government. Certainly right now, we're at a unique time where the CDC has lost a lot of people, USAID has lost a lot of people. I do have concerns that we're at a point that's very different where we were a few years ago.
Yeah, I would say, as I was thinking about your presentation on the communication side of things, I can remember everyone getting, in essence, almost a 3x5 card. It wasn't quite that big. And that the doctor would actually write the date and, no matter where you were, and you had to, I still have that card.
Me too.
But now, I get here from CVS, I hear from, certain medications. I think we're a lot better off from the consumer perspective in terms of what can be available than what was 5 years ago. Question I have for all of you before I yield. So there's been talk about counterfeit equipment. Don and I had a brief conversation up here. It was like, how do you tell? That small print is there, and it's probably identical on whatever device it is. How do you tell that it's counterfeit until it doesn't work? It's almost impossible, I would say, right? For as you generate invoices.
You can go on Amazon and try to buy a ventilator.
Yeah. Did you get it? It's already been delivered. It's already been delivered to your house. What's your means to try and figure that out to make sure you don't get ripped off?
So I would say, at least for PPE, you want in healthcare facilities, you need to have it from an established vendor that's NIOSH approved, and there are websites where you can ensure that this particular vendor is approved by NIOSH, and they have to have a certain trademark and label on it. So, I mean, there are those specific types of factors, but is it 100%?
I mean, I bought a Rolex watch for my son when he was 5, and we have a great picture of him on the street holding next to the Rolex sign in New York, and 10 minutes later it broke. And I could have gotten 2 of them for $15, but I only bought 1 for 10.
That's too funny. That's the beauty of New York. You can get all those things on the streets.
Buy anything on the streets in New York.
I know. All right. Dr. Allen, do you have something you want to add?
Yeah, I think, from the state perspective, I think states are really looking specifically to the federal government for some of that information. And the vetting of vendors and being able to have the listing of approved vendors that have reliable manufacturing processes that are not providing counterfeit medical devices. I think those are some of the things that probably can be done at a federal government level, overarching, that states can then tap into.
Are there strong enough penalties for those that are violators of that, or not?
That I can't speak to directly. I'm not sure.
I'd like to extend it to households, because if you talk about things like masks and rapid tests, every household should have a supply of these kinds of things during the pandemic. And so how do you make sure that those are reliable? I have my own tricks. I go in person to buy it from a CVS or other store. You buy it from a name brand. You buy it, there are all kinds of things. But I do think that we need to think about stockpiles that also get pushed out into households, that people are prepared there at that level.
Yeah. Well, thank you.
Hannah? No questions? Chip?
Thank you. Thank you again, all of you, for what you do, and each of you for what you do, and for being here with us today. I think you've all made recommendations about things that the government should do, the people in this town and the Congress and the executive branch. So my question goes to, have you made those recommendations to the appropriate players in the federal government? And if so, how do you do that? And particularly, I'm interested in, many of us would be because we've served in Congress. Do you talk to your local members of Congress about these kinds of recommendations and ask them to ask for their help in advancing them, either legislatively or in regulation or behavior by the CDC or whatnot? And what has that been like?
So I do sometimes. I've gone in person to meet in people's offices. I've made phone calls on various types of issues, some of the ones from today, some other ones. I'm also part of some organizations that do some coordinated efforts to talk to various representatives at different points in time. During the pandemic, I also spent a lot of time talking with the media and writing op-eds and things like that, because that is another way of pushing the conversation forward and talking about what we should be doing. I'm sure that I should be doing more, and look forward to doing that.
Our members, the state health officials in each of the states, really, we look to them to push information up through their governor, and then information through their state legislators or information that way. Across federal agencies, our team works very closely with folks in leadership at most of the federal agencies that are responsible for preparedness planning and health across the country. So CDC, we work very closely with CDC, other parts of HHS, ASPR. We do have at ASTO an amazing government relations team that works directly with members of Congress and folks directly there, the federal government as well, to ensure that the state health officials are able to link in directly with their members.
Thank you.
Yes, and I'll add on to that. I think one of the benefits in healthcare is we're also able to provide feedback on certain pieces of legislation, as well as any grant opportunities. So, for example, HPP, the Hospital Preparedness Program out of ASPR, I think it was last year or maybe the year before, they wanted to get feedback on the algorithm for funding, and I think there are certain other asks, and so healthcare systems are able to put together their feedback and share that directly with ASPR. Though I will say, I think very similarly, briefly, but on a different topic, as we talk about stockpiles and being able to share our feedback, whether it's with elected officials, whether it's with, ASPR through HPP, some of those funding sources are starting to dry up or they're being challenged. And so specifically as it relates to stockpiles and PPE, within the hospital preparedness program, you have healthcare coalitions that are supposed to keep stockpiles of certain amounts of PPE. Now, if that HPP program doesn't exist, particularly for healthcare, that's a huge blow.
Thank you.
Ken. Just one a take on Donna's question about whether there are any states that have model programs. Any other countries that have, best practices that we could adopt?
I can point to a variety that I looked at for different types of things. So testing, for example, was really extraordinary in a lot of countries, but South Korea is one. I think Germany had a lot. Schools, I know that England did some things in terms of communication. There was work in England and I believe in Australia as well that was effective in terms of modeling. The UK has a lot of collaborations between government and academic modelers, and so they had an early handle on where they thought things were going. And then if you look at other areas like surveillance and genomics, we certainly got some early data out of South Africa that was critical, and they're just one of several examples where there were a number of countries that were earlier in that space than we were.
I might add that Greece had a very good communication system with their folks across the country.
Thank you.
How about specifically like modes of stockpiling and distribution?
Stockpiling and distribution, you said? Well, China has some effective strategies in that respect, both in terms of access to mass, but also in things like early procurement of the sterile glass vials for vaccine or rubber tops. I think that they were able to get out ahead of it, not just because of location, but because they're really coordinated in that way, and were able to get ahead of a number of others. England did, I believe, also distribute rapid tests to schools, and a lot of countries had rapid tests very early in ways that were very meaningful.
I would just add, I think we learned a lot of lessons through the COVID response, obviously, but I think one that we've seen specifically with stockpiling and response is prior to COVID, stockpiling in response to a hurricane or a more regional issue is something that we have done quite often in the country, and there is a lot of sharing state to state. There's a lot of resources that can come to bear for a specific, almost time-sensitive, individual point response in a locality. I think what was so different in COVID, quite obviously, was the national level response that was required from all states at the same time, and it was such a prolonged level of response. And so that was something that I don't think we had quite seen at that level. If you look back to H1N1, again, that level of the extended response and the lack of knowledge that we had in the very beginning about the actual pathogen, I think is something totally different. And so looking at how we can transition our stockpiling from being able to respond to those smaller point time specific incidents or regional incidents into really being able to cover the broad spectrum across the country at the same time is something that we have yet to really look at the actual full bear of the lessons that we've learned from COVID as a nation, and really do an intensive study on what went well, what didn't, and how we can start to move forward and patch some of the holes that were discovered through the COVID response.
Okay, thanks.
And I'll just briefly add, because I think what's really, really important is bringing in the human behavior element to all of this. And so particularly in New York City, when we had our first lab confirmed case March 1st, we all knew obviously it was spreading before then, but the first lab confirmed case was March 1st. PPE burn rates were already pretty high starting in January, and it was because of the human factor. It was looking at other countries seeing COVID cases, and then obviously healthcare workers wanting to make sure that they're protected. So burn rates started to go very high, starting in January, February, before you saw the first lab confirmed case. So it's really important to understand, while you may have a stockpile, that burn rate can go up real fast before you actually start seeing any lab confirmed cases.
Asha?
Thank you, Senator. I have just one question. Sarah, so New York City, you mentioned the evaluation that you all have done with the PAPRs and this issue of the human behavioral aspect. This is something we've heard from the other major metropolitan areas as well. And as I said to one of the previous speakers, it's not particularly about healthcare. It's about anybody that's being asked to put these on. But we understand the desire for something that's reusable and the desire to do better than just whatever everybody happens to have or disposable. So how do you suggest, especially in the major metropolitan areas where everybody's using this stuff, not just for, disease necessarily, how do you recommend that we get beyond this? Is it just a question of the technology being around for long enough that at least the expense comes down and the engineers get in there and engineer something that people will physically actually want to wear and doesn't take 10,000 hours to fit and refit? Or is it something else? Do we need brand new technology entirely?
Yeah, it's an excellent question, and I think my answer is pretty simple. We need to pilot all of these different technologies and all these different assets and devices with actual frontline healthcare workers. And this is not just, clinicians and nurses, but EVS. When we look at allied healthcare professionals, they're also on the front lines. You have, I think data shows an upwards of 15 million allied healthcare professionals in the United States. This is your lab techs, your vat techs, your x-ray techs, clerical staff. All these individuals, interact with patients on an ongoing basis. They should be part of these pilot studies that we're doing to evaluate their comfort level, to evaluate is this something that they want to actually wear for long periods of time. And we see that sometimes, but oftentimes we don't. You see, these kind of rubber stamps or kind of, these statements of like, yeah, this is the best thing for pandemic preparedness, but actual frontline workers have actually not tested it out. And when they have, they don't feel comfortable in it. One prime example from an operational standpoint, when N95s are being deconned, you had to put in some robust policy, something as simple as don't wear makeup because it interferes with the integrity of the PPE when you're deconning it. Having that as a policy, then sharing that and operationalizing that, that's difficult. I know plenty of people that like to put makeup on and lipstick on, and so then you have to throw away those N95s, and so it's really difficult to operationalize some of these things, and that's where I think rubber meets the road is when you actually drill, test, and you pilot, many of these different devices to get the real world experience of does this work, does this not work, what do we have to tweak, and what do we have to change?
Well, I'll just say that the SLTT folks, academia, industry, and the other NGOs are all going to get their chance, it sounds like, pretty soon to do what they think should be done in terms of piloting and purchasing, considering what's happening at the federal government now and the administration's decision to take all the PPE and push it out to the states. We look forward to working with you all on this issue because if it's going to be on the states, I usually say there are two things the states need to implement something. They need time and they need money. And there's no time, and the administration has said there's no money. But this is too important to just let go. We need PPE as much as we need everything else. Thank you.
Thank you, Asha. Rachel, do you have a final question?
No, I don't. Thank you very much for your testimony.
Well, I know I speak for the entire commission in expressing our gratitude to you, not only for your expertise and the invaluable information you've shared today, but for your leadership and your service. We're very grateful. We hope you keep it up. We look forward to working with you. With that, I'll turn it back to our chair.
Thank you very much. Let me thank the panel for your wonderful contributions in educating us and for your leadership and service. And thank the audience and our team, our staff that has put this meeting together. We've been talking about the challenges at heart about alignment, aligning federal strategy with state and local and tribal and territorial realities and the private sector, and aligning public health needs with industrial capacities, and aligning national security with economic security, and aligning peacetime policy with crisis execution. If we get those alignments right, we can reduce risk, we can shorten disruptions, and we can save lives. So pray for our country. Thank you. very much, and happy holidays to everyone.
Thank you. See you next year.
Finished early.